Yes, sir.
Mahalingam sir.
Mahalingam sir varleyano. Mahalingam sir.
Sir, good evening, sir. Sorry, sir. Laptop problem achi, sir.
Vaanga Rajendran.
Sorry, sir.
Good evening, sir. Veldagiri sir. Join pannireenga sir.
Good evening, sir.
Good evening, Raj.
Good evening. Good evening.
Sorry, sir. Ninga appadi upgrade
பண்ண problem ஆயிடுச்சு.
Okay, sir.
இப்ப அதான் ஆஃப் ஆச்சு. நான் தான் போன் கனெக்ட் ஆயிருக்கேன்.
Rajendran.
Sir.
டாப் நல்லா இருந்தா லேப்டாப் சரி பண்ணிடலாம்.
சார் ஸ்டார்ட் பண்ணிடலாமா சார்?
ஸ்டார்ட் பண்ணிடலாம் சார். ஓகே.
சரி ஸ்டார்ட் பண்ணுங்க.
Yeah, good evening to everybody on behalf of IAP TNSA. Welcome and all. First we'll start with the pediatrician prayer by Dr. Gopal Subramanian.
அனைவருக்கும் வணக்கம். குழந்தை மருத்துவ எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயிலும் துன்பத்திற்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்தன் குடும்பத்திற்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாத காரணத்தை ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் நேரங்களிலும் அனைத்து மக்களையும் கொடுத்து அருளுங்கள். நன்றி.
Yeah, thank you, Dr. Gopal. Now I request our President, Dr. Ramesh Babu, to deliver presidential address.
Thank you, Dr. Rajendran sir. Respected past President 2021, Dr. Ismail sir, President-elect Dr. Suresh Balan, respected Secretary Dr. Rajendran sir, and respected Treasurer of IAP TNSC, Dr. Gopal Subramanian sir. Respected office bearers of IAP TNSC and respected Central IAP EB members and respected moderators of today's event, Professor Thangavel sir and Dr. Mahendra sir, and respected juries, Professor PRC sir, Professor B.R. Nammalvar sir, and Professor Dr. V.V. Varadarajan sir, and respected resource persons. I won't take much time. I want to say just only a few words. Actually, this topic, ethics in pediatric practice, along with human values, was I should say it is the brainchild of Professor Thangavel sir, who told that we should reach the practicing pediatricians so that these things won't be available in textbooks. And this will be available only from the vast and rich experience of the legends of our pediatricians from Tamil Nadu, as well as and also the stalwarts of pediatric practice in our state. So we were happy to organize this event on behalf of IAP TNSC. I have seen the preview of the questions which they were working for the past 1 week. I think these things were extraordinary, and each one's contribution is tremendous. Without taking much time, I wish the program to be a great success, and thanks for the opportunity. Over to Dr. Rajendran sir to carry out the proceedings further. Thank you.
Thank you, President sir. Next, I request our President 2021, Dr. Ismail sir, to tell viewers.
President Ramesh Babu, Secretary Rajendran, Treasurer Gopal Subramaniam, and the moderators, jury, and the speakers of the day, and all the delegates who are in the meeting. Good evening to all of you. I welcome to this unique program. Really a matter of time. I think all the pediatricians should have this topic, and it is a genuine program which we'll be cherishing it soon. I wish you all a happy learning. Thank you.
Thank you, Dr. Ismail sir. Now I request our President elected Dr. Suresh Balan to tell viewers. Dr. Suresh Balan is there? Okay, thank you. And respected President Dr. Ramesh Babu and President 2021 Dr. Ismail and Treasurer Dr. Gopal Subramaniam, and on behalf of IAP TNSA, welcome and all. First of all, I welcome our today's moderator, our Dr. S. Thangavela. I think need not have introduction. Dr. E. Mahendran, and juries Dr. P.R. Malwar and Dr. P. Ramachandran sir, Dr. V.V. Varadarajan, and resource persons Dr. Amalraj, K. K.V. Arulalan, Dr. Lalit Kumar, and Dr. Magalingam, Dr. Manohar T.N., Dr. Palniraman, Dr. S. Raju, Dr. Sadish Sir, Dr. R. Selvan, Dr. Sunil Srinivasan, Dr. Thirumurugan, Dr. Vidagiri. On behalf of IAP TNIC, I welcome all the central as well as state IAP members. And for this wonderful CME, I think it's Dr. Tangwell sir took a lot of interest and dedication to make this possible. And it's over to our program coordinator, Dr. Tangwell sir. Please. Sir, please carry on, sir.
அனைவருக்கும் வணக்கம். ஆக்சுவலாக எல்லாருமே வந்து இப்போ 2 years கிளினிக் க்ளோஸ் பண்ணி ரீஸ்டார்ட் பண்ணதுனால இதை தெரிஞ்சுக்கணும்னு ஆசைப்பட்டு தான் அந்த ப்ரோக்ராமை ஆர்கனைஸ் பண்ணோம். We want to learn from everybody how to give a booster dose for our pediatric practice. This is the program for today's and tomorrow's pediatric practitioners and the knowledge shared by yesterday and today's pediatric practitioners. Without wasting time, we will just initiate the program. I think Dr. Mahalingam and Dr. Bithagri has not joined it, sir. One of you, Mahendra, or someone can contact
Sure,
him
sir.
and then.
No, actually, Dr. Bithagri was trying. He was constantly.
Dr. Mahendran sir has joined. Dr. Mahendran is there.
Mahendra join பண்ணிட்டாரு. Bithagri sir-um.
Sir, Dr. Bithagri sir திருப்பி email அனுப்பிச்சிருக்கேன். WhatsApp message போட்டுருக்கேன் sir.
And also Mahalingam sir-um.
நான் செக் பண்றேன் சார்.
Okay, sir.
See this.
Sir, BRN sir wants the current link, sir. He has got the old link.
Sir, current link இதுல போட்டுருக்கோம் சார். நம்ம அந்த குரூப்ல போட்டுருக்கோம். அதுல ஜாயின் பண்ண சொல்லுங்க. அப்கிரேட் பண்ணிடுவாரு.
Okay.
திரு அப்கிரேட் பண்ணிடுவாரு. So this is being a very important program. We have a lot of stars. You see, I don't think any other program had so many stars in this the pediatric practitioners program. I'm thankful to Dr. Mahendra for helping me preparing the slides, and thanks to juries, Professor BRN, Professor PRC, and Dr. Varadarajan, and a big list of faculties: Dr. Amalraj, Sharulal, Lalit Kumar, Mahalingam, Manohar, T.N. Manohar sir, Palniraman, Raju, Satish, Selvan, Sunil Srinivasan, Thirumurugan, and Bithagiri. The production executives are Annamala Vijayaragan. He is going to check the timings and limit us. And I'm thankful to my financiers and producers, EAPT, NSC. Functionaries. With this, we'll move on to the first question to the faculty. நான் 1974 வந்து ஹவுஸ் சர்ஜரி முடித்தேன். 75 ஜனவரி எங்கள் அப்பா வந்து ஒரு 100 ரூபாய் யார்கிட்ட கடன் வாங்கி கொடுத்தாரு. அதில் 25 rupees வந்து நான் அந்த கிளினிக் ஒரு ரூம் கிளினிக்கை நான் எடுத்தேன் ஸ்மால் வில்லேஜில். தட் கிளினிக் அட்வான்ஸ் வாஸ் 25 rupees, rent was 25 rupees. So I spent 25 rupees in paying the advance. Rest of the 75, with that 75.
You're logged in, huh?
Rest of the 75, I purchased a chair, table, and a kettle for boiling the syringe needle, and few medicines. That is how I started my clinic. But now things have changed in the last 50 years. So now a person who has completed his MD Pediatrics or DNB Pediatrics wants to start a clinic. Definitely he needs some guidance. How to arrange and structure the clinic, what all things are needed so that he can plan and start a clinic. It's not given any books. Only from the seniors he can collect the information. We have a team of seniors who are ready to guide us. So I just put the question to what is the structure of the clinic? What are all things are needed? It is still a single room clinic works, or we need a larger areas where reception, toilet, feeding room, waiting hall, and others are involved. I just put the question to Dr. Arulalan to begin with, and then followed by Dr. Viridagiri, Lalit, and Amal. Dr. Arulalan.
Good evening to all. ஸோ நம்மளை வளர்த்தவங்க யாரை பார்த்து நம்ம ரோல் மாடலாக இருந்தோமோ அவங்கெல்லாம் இங்கே இருக்கிறாங்கன்னு பார்க்கும்போது ரொம்ப சந்தோஷமா இருக்கு. சார், without wasting much time, sir, I limit myself to only 2 points which others will not cover, sir. So first thing வந்து what Mahatma Gandhi said, be the change you want to see in life. ஸோ சப்போஸ் நம்ம வந்து நம்ம கிளினிக் சுத்தமாக இருக்கணும், நமக்கு இவ்வளோ நிறைய பேஷண்ட்ஸ் வரணும், நம்ம சர்வே ஆகணும் அப்படின்னு இருந்ததுன்னா ஐ திங்க் வி ஷுட் செட் எவ்ரி திங் பை எக்ஸாம்பிள். Just one example. See, to have an exclusive cleaning person, they'll come only for 8 hours, they'll be paid 8,000 rupees. But our clinic, we have to see in both sessions அப்போ ஈவினிங்க்கு வந்து we may not have a cleaning person. ஸோ அந்த நேரத்துல I buy newspapers. நாட் ஒன்லி ஃபார் ரீடிங். இப்போ ஒரு குழந்தை யூரின் போயிடுச்சு, வாந்தி எடுத்துருதுன்னா டக்குன்னு அந்த பேப்பர் மேல, அந்த யூரின் மேல அந்த யூரின் வாந்தி போடும். அம்மாவை துடைக்க சொல்லுவோம், இல்லை அப்பாவை துடைக்க சொல்லுவோம். கடைசியில் எங்க ஸ்டாஃபே வந்து பெனாயில் போட்டு கழுவணும். அப்படி யாருமே இல்லைன்னா நானே கையை தூக்கிடுவேன். ஸோ அப்போ பார்த்துட்டு ஐயோ சார் கொடுங்க சார் நானே கிளீன் பண்றேன்னு சொல்லிட்டு. ஸோ கிளினிக்குன்னு தனியா ஒரு ஆள் வந்து மோஸ்ட் இம்பார்ட்டன்ட் திங் வந்து பீடியாட்ரிக் ப்ராக்டிஸ்னா வாந்தி, பேதி, யூரின் இதை கிளீன் பண்றதுக்கு நம்ம மென்டலி வி மஸ்ட் பி ப்ரிப்பேர்ட். இது ஒரு பாயிண்ட் சார். செகண்ட் பாயிண்ட் வந்து எல்லாமே மூணே தான், ஸ்ட்ரக்சர், ப்ராசஸ், அவுட்கம். சி ஸ்ட்ரக்சர் வந்து இன்வால்வ்ஸ் மணி. நாம வந்து பெஸ்ட் திங் வந்து நம்ம திறமைய ப்ராசஸ்ல தான் நம்ம கவனம் செலுத்தணும். எல்லாரும் சொல்லுவாங்க அவுட்கம் பத்தி டோன்ட் பாதர் அபவுட் அவுட்கம். இல்ல, வி ஹேவ் டு பாதர் அபவுட் அவுட்கம். ஃப்ரூட்ஸ் ஆஃப் தி அவுட்கம் ஒன் வி மே நாட் பாதர், பட் அவுட்கம் இருக்கணும். ஸோ அதுக்கு வந்து ஸ்ட்ரக்சர்ல வந்து இருக்கிற வாட் எவர் வித் மணி, எல்லாருக்கும் நான் சொல்லுவேன் டோன்ட் பாரோ மணி அண்ட் ஸ்டார்ட் அ கிளினிக். See, if you have water with money, you can always upgrade. Structures don't bother. So, mata answers puttukala, then I give my other answers, sir.
Okay, thank you, Dr. Arulalan, opening batsman. If Vritagiri sir is available, I will go to him. If not, I will request Amal to answer this question because he started his clinic. First time doctor in the family, he started the clinic and successfully running. Amal, your experience.
Yes, sir.
Amal,
thank you, sir. Thanks for giving me this opportunity. Thank well, sir, Mahendra and IAP TNC for giving me this opportunity and to be among this elite group. That is, you made my day, sir. So actually, as you rightly mentioned, sir, actually, as far as the clinic establishment is concerned, the pediatric clinic the look is very, very important, sir. When it comes to, because we have to be it's a challenging thing to be a pediatrician and to be a successful pediatrician, sir, actually. And we need to have space, as rightly pointed out. For a city level practice point, it's not that easy, sir, to get a big space. It's 800 square feet mala vechada, we have to keep a play room, we have to keep a feeding room for the mothers, etc. But for a regular newcomer, it will be very tough, sir, actually. When it comes to rural and semi-urban areas, the things are a little easy. That is how I started my practice in OMR. It was a suburban place when I started, sir. That is one thing, sir. And one more thing is, what I would advise you is, to advise my friends is, always stick on to one place, sir. You see, I faced that difficulty, actually. Initially, I started in 2 places, thinking that 1 plus 1, 2 places will improve my practice. But if you are going to practice in 2 places, it is 1 plus 1 will become 2. But if you're going to sit in one place both in the morning and evening, 1 plus 1 becomes 3, sir, actually. So that is one thing from what I learned from my mistake. And now I've changed it, sir. And so that is what I would like to add, sir.
Tirumurugan, can you make me as a host? I can't project my slides. Thiru, please make me a host. I want to project.
Done, sir. Funny answer.
Sir, I am present, sir.
Sir, I am present. Vritagiri is present.
Yes, sir. Yes, sir. Welcome, sir. Welcome, sir.
Thank you.
These are my initial slides. I could not present, so I just show the slides. Hippocrates, the father of medicine, the list of our faculty, production executive, and our I'm thankful to the financier and producers. Coming back to, we are in the first question, sir. We started with the structure of a clinic, how a clinic structure should be arranged. Dr. Arulalan and Amalraj has contributed their answers. I request you, sir, just initially when I started the practice, I started the 1-room clinic, 10 into 10, 1-room clinic. What do you advise for the youngsters to prepare the structure of the clinic or arrangement of the clinic, sir? Vritagiri, sir.
Start with a small clinic, outpatient clinic, with basic facilities like a toilet, a counseling room. I have a consultation room now, which is about 1,200 square feet, having a reception, consultation room, injection or procedure room, then a small pharmacy, and counseling for especially breastfeeding and diet.
Sir, if I can interrupt you, what was your structure when you started the clinic? When did you start the clinic, sir? First clinic.
I started in Tanjavur. Started in
which year, sir? Which year? What was your area at that time, sir? How much?
At Kadalur 76, I started.
So what was the size of the clinic at that time, sir?
That was just a iron size about 150 square foot.
Okay, sir.
No waiting place.
Okay, sir. Thank you, sir. Can I move to other faculty, sir? Thank you, Mridagiri, sir. If you have completed, I will go to the next faculty, Dr. Lalit.
Yes. Good evening, sir. Thank you all IAPT, NSC and Dr. Thangavel, sir, for giving me a chance. I totally agree with all the other people who just, my friends have said about the reception, toilet and all. Reception is a place where the patient comes first contact before contacting you. So that place should be a very, very colorful and good ambience. And about the reception and the waiting room, it should be a little bigger one, because many times we see our kids who come, they come with the father, mother, and sometimes also with the grandparents too. So we need a bigger space, especially the waiting hall should be a little bigger one. And choosing a good location when you start a clinic, it should be a good location with easy access, and I think little bit of at least two-wheeler parking. So it will make easy for people to come around there. And about the examination room, and examination room can be also be converted into a treatment room where you can have a bed. So you can emergency start a fluid, and also you can use it also for a nebulization in the same room. The nebulization also can be done without any disturbance in your OP. And about the toilet, everybody has said. And most important, when starting a clinic, you need a permission from the government. You need to do a Clinical Establishment Act. That is most important. And biomedical waste have to do with the local corporation to dispose of all the vaccine and other medications, what and all you have used it, you cannot throw in the regular dustbin. Make sure it has been only segregated and given through the biomedical waste. And if you plan for future expansion, have a bigger place so that extra consultation room or lab or pharmacy, those things can be added in the near future if you want. I think I have added, sir. Thank you, sir.
Thank you, Lalit. Excellent message. You have to get a permission from the Establishment Act, from the corporation, I think. From this, I'll move on to Dr. T. N. Manohar, sir. Sir, what are the basic requisites for practice? What are the things needed? Now you occupied a room. Now, what are things essential? What are additional requisites? T. N. Manohar, sir. T. N. Manohar, sir.
Yes, sir. Good evening, everyone. Am I audible, sir?
Audible and visible.
Yes. The basic requirements for practice are, in the waiting room, we can put up a electronic weighing scale for both infants as well as older children. Then anthropometer or the stadiometer for height measurement, an inch tape, and infantometer for measuring height and head circumference. That our staff can do it. Then in the consulting chamber, the minimum requirement is stethoscope, torch, tongue depressor, percussion hammer, pulse oximeter, BP apparatus. With this, most of it will be sufficient. If we are going to give immunizations and injections, a refrigerator, disposable needles, syringes, antiseptic lotion, and cotton and plaster is required, and a tray for keeping all this. If injuries are treated, probably related material like cotton, gauze, dressing pads, antibiotic powders, ointments, normal saline, and betadine lotion, such things have to be kept. A couch is mandatory. Emergency drugs we need to keep for treating convulsions like injection midazolam, fosphenytoin, levetiracetam for people who are already used to using it. And for hypoglycemia, 25% dextrose solution should be kept. For anaphylaxis, injection adrenaline, injection ranitidine, injection hydrocortisone, and phenyramine maleate can be kept. These are the minimum requirements.
Thank you, sir. Just an additional question for Dr. BVV. Sir, do you have a CCTV camera in your clinic? If so, what is the purpose, sir? How it will be helpful for patient management? Same question goes to Lalita also. BV, sir. Varadarajan, sir.
He has to unmute.
Yeah. Sir, I also started in a one-room clinic like you in 1975. When I could not afford a bigger place, I moved into a polyclinic. Then I could afford a bigger place. I had shifted my clinic to my house. So now I occupy 1,500 square feet in the ground floor of my house. I have a consulting room, a reception, a feeding room, a nebulization room, a lab, X-ray, and a pharmacy. We have to have, when you have so many things, to know what is happening in these places, we have to have a CCTV camera. For the last 5 years, I'm having a CCTV camera.
So tell me one advantage of it, sir. One advantage for the patient.
When there is a commotion in the reception, when somebody is fighting, because you are sitting in an AC room with a closed door, you may not hear the shouting well. But when you have a look at the screen, you will know somebody is fighting with the receptionist. You can go and diffuse the situation, solve the problem.
Thank you, sir. Lalit, just only 30 seconds. I think you have told me already one advantage of keeping a CCTV camera outside.
I mean, what I usually look in the CCTV is a bigger child being carried by a parent. A bigger child cannot be carried by a parent unless otherwise he's a sick child. He may be physically challenged or mentally challenged. What I think is bigger child, I picked up a lot of dengue fever in my clinic practice usually. A lot of dengue, 8-year-old child being carried by the parent, immediately seen the camera, come and see that child. That child will be in the shock. Immediately a bolus will save the child. That was the biggest advantage which I had with the CCTV.
Excellent, Lalit. I will move on to the next.
Sir, Tangavel sir, ஒரே ஒரு பாயிண்ட் ஆட் பண்றேன் சார்.
Yes, please.
சார் கிளினிக் சின்னதா ஸ்டார்ட் பண்ணாலும் அர்த்தமா இருக்கணும். நம்ம இவர் சொன்ன மாதிரி அமல்ராஜ் சொன்ன மாதிரி கிளீனா அழகா சின்னதா இருந்தாலும் அர்த்தமா இருக்கணும். நம்பர் 1. தப்பித்தவரி கூட மெடிக்கல் ஷாப்ல போய் அட்டாச் ஆகக்கூடாது. உங்களை தலை அட வைக்கிற மாதிரி அது கஷ்டப்பட்டு காலம்புறா படிச்சுட்டு போய் மெடிக்கல் ஷாப்ல அட்டாச் ஆயிடாதீங்க. ஃபார் நியூ பிராக்டிஷனர்ஸ் ஆர் நியூ கமர்ஸ் இட்ஸ் வெரி வெரி இம்பார்ட்டன்ட். வை டோன்ட் கெட் அட்டாச் டு எ மெடிக்கல் ஷாப் ஃபெல்லோ அண்ட் கெட் யுவர் ஹெட் இன்டு தேர் திங்ஸ். நம்பர் 2. Third thing, very very important, immunization கொடுக்குற மாதிரி இருந்தா basic resuscitation kit, oxygen இருக்குதான் கம்பல்சரியா it should be there. அவ்வளவுதான் சார்.
Thank you. Exactly, very very essential points.
Can I add one point here?
Yes, Mahinder.
So newcomers, I think, start small and grow bigger. So initial financial pressure, I think ethical practice is possible. When you're under lots of financial pressure, I think ethics கொஞ்சம் compromise ஆற மாதிரி ஆகும்.
No, I don't think so. I'm sorry to interfere.
Sir. Okay, sir.
Sir, one point I just want to.
Sir, please, sir. 1 minute, sir. 1 minute, sir. If we deviate too much, probably we may not move from the first question. My production manager will stop me, sir. So maybe only 30 seconds for VV and 30 seconds for Satish. Yes, sir.
You don't own the medical shop. You have a medical shop. Leave the medical shop to him. I'm only charging a rent for the medical shop. The number of medicines he sells is his own. So if you have this attitude, don't want to have a bite of everything. If you are happy with the money that you earn in your clinic, you will not fall a prey to the lab or the medical shop.
Thank you, sir. Satish.
Sir, one epinephrine injection should be loaded and kept when we are going to do immunization practice.
Fantastic.
Whether use it or not, it can be disposed at the end of the day. Pray to God that you have not used it. So that should be at the beginning.
Only one doubt, Satish. Because once loaded, how long you can keep it, and how in a year, how many anaphylaxis you face, sir? Can I have time to load it? Will take only 15 seconds. No, if it is available immediately.
It is just a preparatory, because it could be expiry date, it could be broken ampule, and therefore I just want to make sure that it is searching for its diluent. Just make it load it in a syringe and keep it. I am happy if I have not used it that day.
Okay, sir. Thank you, sir. Thank you. I'll move on to the juries. Professor BRN. All of us know Professor BRN is the greatest pediatric nephrologist of the country, but he's also a very very busy pediatrician who was practicing up to midnight. He used to see so many patients. So he will have his own knowledge to be shared with all of us. Sir, Professor BRN has joined, sir. BRN, sir. Till BRN joins, I will request BRN.
I joined. Thank you. I just joined.
Thank you, sir.
Yes, sorry, I'm being late. I don't know how to.
Not at all, sir. Later on, latest on the sir.
Thank you.
Calling, sir. Yes, sir. Sir, we are discussing about starting the clinic, and a youngster wants to start a clinic. should he start with our 10 to 100 square feet single room, or an area of 1,500 meters, 1,500 feet, with multiple play areas, toilet, reception, feeding room, everything, sir. Just I want your advice to be shared for the today's and tomorrow pediatrician, sir.
What has been discussed till now,
yes, sir,
that it's just not simply a single room is not sufficient. Maybe sufficient some 20 years back or 30 years back, it would have been all right. Now I think it's very difficult, especially with the Clinical Establishment Act in thing. We have to follow, including we must also have fire hydrant also near your electric box. So we have to follow
fire
according to the rules.
extinguishers. Okay.
So I think what recently Dr. Lalit Kumar, the other side is great. I think that's apt. It's very difficult to start a practice like years ago, as Dr. Varadarajan is saying, I started in 100 square feet. But that was not possible. I agree with what the current young people have got there.
It is not easy, you feel, sir. Like, it's not easy.
No, it's not easy. Especially the Clinical Establishment Act is very, very difficult. They ask you if they come and check you now and then. A lady doctor comes and checks up. So many things are there.
Thank you, sir. Shall I move on to Dr. PRC, sir?
Yeah, go ahead. No, thank you.
Dr. PRC, sir.
Sir, I agree with all the points raised as starting in a small way, then building up. But as even a small clinic nowadays requires all the statutory requirements, which are also explained very well. So it's becoming, as a matter of fact, a lot of requirements are there. And we have to know what are the legal requirements. Lack of knowledge is not an excuse for anything. So we have to comply. And with the help of some local IMA and other things also, we can have the contacts of whom to get this proper things to be done. That also will be very, very helpful. And lastly, regarding one point regarding the adrenaline, recently there was some thing regarding the shelf life. Once you load adrenaline and keep it, I think it is fairly long, not less than at least 1 month. Only thing is, you have to be very, very careful when you load an adrenaline and keep in a syringe. It should not be inadvertently used for any other thing.
Somebody else. Yes, particularly like a daily one for the vaccine. Thank you, sir. Thank you very much. I think you also told very important requisites, sir. You used to say one important thing must be available in the clinic. I don't know whether you forgot it or not. Yesterday you told, sir.
Yourself.
Pediatrician should be available, you said, sir.
I think yourself.
Yeah. Yeah, ourselves. We should be there. We should be there. We are the prime deity in the clinic. When we are not there, that is the most important. First requisite is pediatrician himself. Thank you, sir. Thank you very much, sir. This is, I collected from most of our faculty have contributed their pictures in their clinic. Like you see here, ambu bag, there is a spacer there. And then Venflon, it's a drawer cupboard with 2-3 drawers. You can keep all the equipments here. So that at the same time, one thing we should remember, we might know being, suppose a child with anaphylaxis, everybody, who are the assistants we have with us, say the nurse or the cleaning person, everybody should know where the ambu bag should be available. They should not search all along. So all these essential devices should be known to everybody working in the clinic. So this is oxygen concentrated. So it looks more economical than keeping a cylinder. Of course, pulse oximeter is almost become like a coffee filter coffee dish now. It is definitely needed. Everybody should have a pulse oximeter at home. And the thermometers, NABP, non-invasive BP monitor. And then this is a simple way to remember what all we required. Soap me is a simple mnemonic to remember what all you should have in our clinic or wherever the place where we practice. Suction, soap me, yes, is suction. Even a bulb sucker sometime may be helpful. Or you can have a good suction apparatus. Oxygen delivery device, either a cylinder or the oxygen concentrator. Airway adjunct like bag mask. Of course, laryngoscope, ETT may not be useful in the clinic alone. We can't manage it. But you should have a good bag mask, a pediatric bag, and 3 different masks. One for the infant, one for the pediatric child, one for the adult. One bag and 3 masks. Protocol, particularly for anaphylaxis. Medicine, everybody said adrenaline is a Vinayaka for our clinic. Without Vinayaka, no temple will be erected. So adrenaline, equipment is pulse oximeter. That's a soap. You can see this here. This is intraosseous infusion. Sir, can you please mute, sir? Can you please mute, sir? So this is intraosseous needle may be very, very useful. Sometimes we'll receive a child with reversible shock. We can't start an IV line. Even before shifting, intraosseous can be and then IV drip stand, IV bag, and drip set. All this. Once Professor BRN said, if we give a vaccine and child develop anaphylaxis, the child get into problems. Some mishap happens. If we write an adrenaline to the father to procure from the pharmacy or the IV bag, then we will be put into problems. If we have everything and we are adequately managed, probably we may be pardoned because nothing else can be done. Nobody can predict anaphylaxis. You can give an adrenaline, you can start an IV lane, you give oxygen, you start bag mask ventilation, shift the child to nearby hospital. Probably that is the best duty anybody can do at the time of crisis. This again, everybody knows it. That's for remembering. We should have one ml syringe. 1 ml syringe with 100 divisions so that the dosage will be easier. Long needle for IM needle, it's not a subcutaneous needle. So this subcutaneous needle should not be used because only IM injection adrenal is useful in the presence of anaphylaxis. EC dose given as 0.5 ml is the maximum dose for adolescent. 6 to 12 years 0.25, 2 to 5 years at preschool children 0.1 ml, and less than 2 years 0.06 ml. That is possible within 1 ml syringe. This is in the waiting room. We can utilize the waiting time for teaching them about the developmental milestones, growth charts. This is shared by Dr. Arulalan's clinic. And finally, I just want to, we talk so much about the practice. There are a lot of our colleagues, senior teachers who served, Professor Jayam, Dr. Sai Lakshmi, Professor Pushpa, Dr. Satya, and Dr. Chandra. Still, all of us remember them for their service. They never thought about self. They thought about only the person sitting on the other side. So with this, we will move on to the next question, patient management.
30 minutes over, 9 more topics. First topic is over now. I request the audience to put their questions in the chat box.
In addition, I also request the viewers to what points we are going to discuss in part 2. This is part 1. Part 2 will be next month. What are the points you want to discuss in this part 2 session? You can post in the chat box. Sorry, Vijayaram sir, we are going very slowly. We'll move.
Yes, sir. We have 9 more topics.
The patient management, now from structure to patient management. How many patients you see? I know most of our colleagues, you see large number of patients. How many patients you see in 1 hour? To begin with, Mahalingam sir. Sir, 1 minute, sir. Your answer should be less than 60 seconds, sir. How many patients in an hour you can see during the usual days, during the rush hours? Please unmute, sir. Unmute, sir. Yes, sir.
Usually, I will see at least 15 cases per hour. And this is my nominal speed. Suppose if a lot of crowd in the outside, the most important thing, somehow or other, we have to engage them. Either my junior will go out and they will talk to them, and somehow they will engage that. And suppose number of cases are very much waiting, then I will increase my speed up to 20 per hour, 20 cases per hour. In that case, I already explained that I have 3 chambers, and through that within one room I have 3 chambers. Otherwise, each chamber will have that couch and all. The sister will put 1 patient in the couch and totally undress the child, and they will be waiting. So I will be moving in each chamber, and my assistant or my staff nurse will write my notes and all. So I can pass on, and the unnecessary talk will be avoided in such a way. And so if the people are not undressed and ready, then I will go to the next chamber. So that next round I will come, they will be prepared. So like that, we can try to push on the cases as early as possible.
Thank you, sir. I think you are the fastest scorer in our part of the country, I think. So I'll move on to Satish.
Sir, thank you, sir, for giving the opportunity.
60 seconds, sir. 60 seconds.
Yes, sir. Yes, sir. Thank you, sir, for giving me the opportunity. Coming to the point, I really congratulate Dr. Mahalingam, sir, at the highest speed. But actually, what I feel is I do give appointments in slot 5 to 6, 6 to 7. In a slot of 1 hour, I give appointments only for 5 patients. So though I may see about 6 or 7 in this hour, the remaining time is used for accommodating unlisted emergency patients. Some people come unlisted, either because they don't know or because they don't know the appointment system, or they have found it necessary to see in the early part of the day or some other. It is useful for, they could not wait till their turn comes. So an additional patient is accommodated who is not listed in that slot. Second thing is phone calls. Third, some patient who might think that appointment is not necessary to only to show the reports. The one who has been seen the previous day, he comes to show the report perusal. So we have to, these things do happen. Sometimes the reps also may be coming 1 or 2. Instead of calling all the time, all the reps in 1 hour, we can now split them and come whenever they come, we can accommodate them. So to accommodate all that, I just 10 minutes. For one patient, I get about 50 minutes, and remaining 10 are accommodated for these due.
Thank you, Satish. You have a broader umbrella to include everybody. I will move on to Dr. Raju. Sorry, Dr. Raju, you said you have some appointment. I just delayed it. Dr. Raju, another 5-10 minutes I can release you.
Thank you, sir. Good
so
evening,
how many
everyone.
patients you see in 1 hour? Okay.
Yeah, I also see like Dr. Satish, it will go on ordinary days up to 8 to 10, and sometimes the busy days when you get season of acute nasopharyngitis or coryza, it may go up to 10 to 12. But we may have some time in which you can accommodate walking newborn, walk-in sick case, or as I said, some patients may come with the report without the patient. Those can be accommodated in that period. So maximum I would see around 8 to 10.
Thank you, sir. Hope you will be staying in for another 5-10 minutes. I have some more questions to you. And Dr. Paniraman.
My thing goes along with the Dr. Mahalingam pattern, a minimum 15 patients and maximum 20 patients per hour. It's the need of the hour. No other go. We are in a tight-lipped situation. But only the pattern recognition, as you advance in your practice, your pattern recognition helps in deciding the treatment.
So we have 2 Hussein Bolt in our batch, I think.
Shall I add one more point, sir?
Sir, 10 seconds, sir. 10 seconds.
Yes, sir. If suppose the patients are coming with a heavy file and all, then I know that already we are seeing that the child is a cerebral palsy. So we need not to spend much of the time. In that case, I will ask them to give all the reports, because they will have some Cctv 3, 4 and EEG, everything. I will ask them to put it in my table and ask them come after 2-3 days later. I will go through that in the after my OP is over, and so that we can cut short the time in that way. Of course, real emergencies, of course, long cases, we have to spare much more time.
Thank you. So probably you can even get your assistant to go through that.
Yes, sir. They will go through
an hour.
that,
We can see them.
So we can.
Thank you, sir.
Thank you.
Thank you, sir. Thank you, Tirumurugan. I think you fix up appointment. You go in a very proper way, standardized way. I think.
Yes, sir. My outpatient is very much regulated one.
Structured.
Where they have to book appointments the previous day through WhatsApp these days, and we give 10-minute slots for every patient. So if some in between patients walk in, if there is emergency, they have to go to our emergency department and then get referred from there to me. So one thing I do for the management of the crowd is to give alternate OPD numbers, broken numbers. So it will be 101, 103, 105. So if a patient has an emergency or has to walk in, so the staff has got a right to slot them in between. So whatever limited time I can save in between, I use it for those patients. So, but usually 6 or 7, not more than an hour, in an hour, and not more than 25 patients in the morning and maybe another 10 in the evening. That's all, not more than that. Sir.
Great, very structured. If I urgently come to Pondicherry and I want to meet you, how to get your appointment? Waiting the reception.
It's not easy, sir.
Thank you.
Specifically WhatsApp or phone call, sir. On a specific time, 3 o'clock.
Just for fun. Okay, thank you.
Serious away. I don't accept emergency appointments.
Even Professor Srinivasan?
Yeah, sir.
Same answer. Okay, thank you. Okay. How do you manage a large volume of patients during busy times? Many patients are waiting outside. I asked the same faculty, but please answer within 10 seconds, sir. Large number of patients, busy times, many patients waiting outside, and there is an argument outside for a long waiting time. So,
sir, whatever the large number of
10
patients,
10 seconds.
Whatever the large number of patients, by 10 o'clock, 11 o'clock, how much you have to finish. You go by your own speed, because you are in the maximum speed and top gear. So more than that, if you go, you will collapse. So you have to go in the same speed and you have to keep yourself cool. That is the way you should go. Number two, try whenever there is an argument outside, better not to go outside because you are already in a tense situation. You will lose your temper. Number two, so maximum try to mostly the staff will settle the problem most of the times because whenever you go out and lose your temper, the aftertaste will be worst. And the next 10 to 15 patients, you will not be able to see properly. So better don't get into an argument with the patient. So always in my outpatient, I'll have அமைதியாக பொறுமையாக வர முடியாதவர்கள் தயவு செய்து இங்க வருவதை தவிர்க்கும். இப்படி ஒரு பெரிய போஸ்டரே ஒட்டி வச்சுட்டேன். அவன் முடிஞ்ச அளவு யாராவது சத்தம் போட்டாலும் வெளில வந்து அந்த போஸ்டரை காமிப்பேன். அமைதியா இருக்கணும் இல்ல பொறுமையா இருக்கணும் இல்ல தயவு செய்து என்ன விட்டுருங்க. This is the way I go about.
Okay, thank you. Wife எப்படி நடந்துக்கணுமோ அப்படி நடந்துக்கிறீங்க. Then Satish, how do you manage argument outside? 10 seconds, sir.
Argument outside is usually because when I'm coming late or when I have to be when I go out during the working hours during unscheduled work, like for example call for a cesarean resuscitation, or when I go to the hospital for emergency work when there is already admitted patients becomes more ill when I'm compelled to visit. So such a backlog of work comes only then there will be a backlog and therefore the queue will be there will be a hold up and there may be an argument. In which case we have to tell the receptionist to tell the doctor had to go for an emergency visit and therefore the politely the receptionist has to answer. If what the receptionist says they are not taken up by the patients, I generally come out and tell them, see, I had to go and that's why this has happened. I will try my best to accommodate you as early as possible. Generally, when we come and plead, the parents keep quiet. They do not pick up the argument.
Thank you. Thank you. Now I'll ask Dr. Raju to answer two questions. One is again the same thing. Argument outside, how do you manage? 15 seconds, sir. Raju, sir.
Usually, when there is a heated argument outside, I'll go out. I'll go out and talk to them patiently. That I'm also engaged. I was busy. I was engaged. And most of the times, 90% of the times, they will be listening. And the receptionist will be asked to send the patient as early as possible inside, probably within 10 seconds, 10 minutes or so, and they'll be willing to accept.
So next question to you, because I don't want to lose you. A VIP suddenly comes without appointment to your clinic. VIP, you can imagine anybody.
Yes.
Coming without appointment, he comes there from the reception. So the whole reception is now disturbed. How do you manage, sir?
Yes, it's a district headquarters. So most of the VIPs you would say will be officials, and there will be, of course, 10 to 15% will be the politicians. Usually give them the time. We have a side room in which they will be asked to sit with the AC comfort and all. And in the time when somebody will be taking the temperature, pulse oximetry and all, and they will be amused. And within that time, I'll prepare myself. Or if it's a big VIP, like the local collector or DG or somebody who has brought his son or daughter, I'll request the person whom I am examining, the collector has come. So I have to go out and see him for 5 minutes. Just excuse me. They will definitely be in a position to accept. This can happen in a place like it.
Thank you, sir. Sir, how many doors are there in your clinic room, sir? Two doors are complete.
Yeah,
two doors must be. That is a very important strategy, I think. And we also told once, in the clinic room, there will be 2 doors so that
there should be a side room. That should be an escape.
Move out, escape route, for a cup of coffee or to see a VIP or some reason. Right. Thank you, sir. Thank you very much, sir. And coming back to Mahinder, everybody is talking everybody, whole clinic is busy after the COVID. Now, do you still continue vaccinations? And still you may have to talk something about vaccination and development. How do you do it, Mahinder? I've seen Mahinder clinic very busy. At the same time, when you enter, Buddha will be sitting there with all the calmness. When you go inside Mahinder clinic, it will be very nice. How do you manage vaccination and well-baby clinic during rush hours, Mahinder?
I do not have a separate vaccination time slot or a well-baby clinic. So it's a mix of all patients. During very busy days, I tell them that the clinic is crowded. Write down the questions, and during the next visit, I'll answer your questions. That is one. And number 2, during vaccination time, as I'm logging and giving the vaccine, and talk about development of the child and dietary advice. So 2. And nowadays, post-COVID, there are lots of issues with development and anxiety and communication skills. So I give focus to toddlers who are entering the clinic with for other reasons. I ask them whether the child is having good eye contact, socializing. So this is how I manage. So I do not have a separate slot. I explain the patient on busy hours to have the question for the next visit.
Thank you, Mahinder. Can I ask Selvan? Selvan, again, the same question. How do you manage the arguing patient? Second one is a VIP visiting your clinic without appointment. Selvan.
I'll just come out and ask the parent to come in. I'll ask them what is the problem so that I will listen to them.
Sir, Selvan, your voice is louder. Probably you can reduce the volume or
okay.
Speak without mic. Okay, sir.
Okay. Is it okay, sir?
Now it's okay, sir. Okay.
So I will ask them the problem and what is his grievance. If he tells some grievance, I will listen to it and then I will tell them I will take care of it. Then I will examine the patient, take my time. I will not criticize. I will not scold him. Then send him like any other patient.
Thank you, Selvan. VIP visits. VIP visiting without appointment.
For a VIP, the child is a child, whether it is born to a VIP or an ordinary person. So once they come in, talk to them as like any patient, examine as usual, don't argue, criticize, comment on their sudden intrusion in your clinic. If they sense that they are not given special treatment, they visit one of our colleagues for the next illness. Only people who like your way of practice will be your regular customers. One less VIP is one less headache.
Thank you. I think everybody will do it in a comfortable way, which is comfortable for them. I will move to the juries.
Sir, handling pseudo VIP, sir. This is sir. Handling pseudo VIP.
Like when you controversial, we'll decide VIP or pseudo VIP. We may not be able to, whichever is comfortable for us, because we can't. It is a very difficult world, so we can't develop problems around us. Sir, I move to the juries, sir. Professor BRN, sir. Same thing, sir. Argument outside and VIP comes without appointment. Professor BRN, Professor PRC, and BVS.
Shall I say?
Yes, sir. Yes, sir. Yes, sir. Please.
Yeah. So I do agree that sometimes there is somebody breaks a queue or comes this thing, the others raise a problem. And in that case, sometimes you have to go out and pacify that it is a mistake. So we will see the next person as soon as possible. So generally, going out, our talking generally pacifies most of the times. The second thing is regarding the VIP. Again, if it's they are coming out of the queue, I do the same thing as Dr. Raju. Just take the permission from the next patient that so he's a very, very known person or sometimes my teacher or senior. So I'll have to tell the reason. I will see as soon as I finish with them. Most of the times, the next patient they do agree, so they do not have any problems.
Thank you, sir. It's a via media, very good arrangements. One of the VIPs from VIP parents from the PRC clinic helped our diabetic patients for almost 4 or 5 years. They contributed money to buy insulin, do the lab test. So attending to VIP is also not only useful for us as well as to our patients also. One of the VIP contributed money to do investigations as well as drugs for the poor patients with diabetes. Thank you, sir. Sir, BRN sir is available. Sir, Professor BRN sir.
I'm here.
Yes, sir. Sir, we are discussing about how to manage when there is a argument going outside in the clinic waiting room, or a VIP suddenly comes, how to manage them?
I fully agree what has been discussed. Only one more thing I'll add is, when a patient argues fighting, I just come out and tell the parent, please wait. I will not leave this place until I see you. I assure you, I'll see you and then go. That will make them very happy and they stay back. You can control their anger.
Thank you, sir. Very simple way to console them and come along with us. Thank you, sir. With this, I just want to sum up with the last two questions. I have three options, sir. The person who is going to start a clinic, a youngster, has got three options. First option is the best option. He's fully ready for private practice. He thinks, I'm not going for a job. I'm not going to do a post-graduation, super-graduation beyond MD or DNB, but I'm going to be fully engaged in private practice. I have enough funds. So it's better for him to start a full-fledged clinic. He wants to establish a practice. No, got enough funds. Probably he might, from the beginning itself, some of our colleagues tell that from the beginning itself, better to have everything, like a good room, clinic room, consultation room, reception room, feeding room, play area, everything can be, if it's possible, probably that's the best option. In that is this thing is, he definitely want to go for a private practice, but currently he doesn't have fund to go for a very big establishment. And those with the scarcity of fund, they can start with option 2 or option 3, and then later expand depending on the response and fund. That's what many of our colleagues are told. So what is the second option is, initially you can take up a smaller area, 10 to 10 square feet, small area. Maybe after 3 to 4 years, he can decide the practice is picking up well, he can expand, or we can look for an alternate options. Initially single room practice, then he can expand and go for a higher ups. Third one is, I want to do practice, but right now I am not very clear how long I am going to be in the same city. My marriage, place of practice, pursuing alternate options to go for a job or PG. I'm not very clear about it. Better you get a sharing consulting room in a polyclinic or hospital, where you are not expected to invest money in that. Only that probably you will be ready to share your consultation to the polyclinic or the hospital owner. These are the three options. We thought it will be useful for three different type of person who want to start a clinic. So father of modern medicine is Hippocrates. Hippocrates is ancient medicine. Modern medicine, William Osler. One of the first duties of the physician is to educate the masses not to take medicines. Paradoxical advice. As we grow older, we follow that advice. Now coming to third question is for documentation. See, how many of us write the OP prescription? Do we write it, the handwritten one or a digitalized one? If it is handwritten, either I am going to write or I will dictate and somebody else, an assistant or nurse will write. Whether we ask the reception assistant to write the initial data, name, date, time, pulse oximeter, saturation, heart rate, everything. How to avoid the errors in the prescription, how to avoid it. For this, I invite Dr. Sunil. Sunil has been silent for a long time, but Sunil. Dr. Sunil Srinivas.
Yeah. Am I audible, visible?
Yes, sir. Audible.
So I have been using computerized prescription for more than 10 years. For the first 6 years, I was using my own kind of system, which was very good, very comfortable. The only problem, I'm not able to store my patient's data. So past 4 years, I've been using IAP software. Works very well. Describing IAP software takes 1 day, but just to make it short, it's a complete program in itself. You can manage all your clinical affairs using. Thank you.
Thank you, Sunil. I think how much time it takes for you to, Sunil, to document, write the prescription?
I just to complete, I take about 8 minutes per patient. And for the first 2 or 3 minutes, I ask the parents to keep quiet. I don't tell you, please keep quiet and just let me observe the child. It has helped me a lot. I am seeing the patient without any bias. Next 4 minutes examination. It takes only 1 minute to generate the prescription. I already sent you a sample there. So 8 minutes, you can do a lovely job. Thank you.
Thank you, Sunil. I think Palninaman also fall in line with Sunil's plan, I think. Palni, how do you write your prescription?
Yeah, nothing more to add, sir. But it is very, because you get a very digital prescription. At the end of the prescription, you sign. So before signing, you will verify whether any errors are there or not. and then you give it. And because it is a very legible and clear, and the data is there, so errors are very, very minimal. So once you are, because nowadays the students are tech savvy, so it is very easy to follow the IAP software.
Thank you, Palani. Satish?
Sir, actually, I practice a mixed system. When I'm practicing
I think in the
Apollo,
clinic you will practice, and in the Apollo
yes,
different. Yes,
yeah, Apollo it's digitalization completely, and I have an assistant to type whatever I say. So the digital prescription is given, and in fact MCI prescribes e-prescription only for clarity and reproducibility. But in the clinic, actually it's a written prescription. I've not yet gone totally digital, but I installed a doc-on software, but I'm partly implemented it. But in this available system is that we prompt the prescription by the receptionist writing the name and age, date of birth, correctly calculated age, weight, height, and also the point where the patient's weight and height stand as per the IAP chart. That is between 3 and 10 centile, 10 and 25 centile, like that. And for this vitals also are entered there before the patient enters the chamber. I have a 2-chamber system where the second room is there. The previous
left ventricle, right ventricle, sir. Left ventricle, right ventricle.
To be seen patient is seen in the second waiting hall, and so that we tell the mother to open the shirt and keep it so that the next one to enter. Then that's how writing the prescription is handwritten, and deciphering the prescription is with the help of the receptionist.
Thank you, Satish. Sir, Virthagiri sir, 15 seconds, sir. Can you briefly tell, sir, what is your way of writing?
I do by handwriting only. My handwriting is reasonably legible. Another thing is, whenever I make some point, I write it on the side that I have highlighted this point. Next time when they are coming, they cannot say that you have not said these things. So other than prescription, I note down certain points which I am discussing with the mothers.
Thank you, sir. Thank you very much, sir. Arulalan, then followed by Lalit. Again, 15 seconds, Arulalan. The prescription writing is digitalized or self? You dictate or you write by? Both.
Both, sir. The English part is by
Arun, sir.
Interpreter,
sir, initial part is combined, sir. Handwritten by the staff.
Thank you. I think we have some disturbance in the Wi-Fi.
Kekala.
Okay, Lalit. Move to Lalit. Lalit?
Yes, sir. I'll add up 2-3 points.
Again, 15 seconds, Lalit. I can just add extra points alone. Okay.
Sure, sir. So the receptionist writes the prescription and send inside. It is prior, when the patient comes, priorly the prescription is on my table. So you just make double sure that there's the same patient name whom you are seeing first. And second thing, the error occurs one more time when the patient goes to the pharmacy. You have seen the patient today. The next day when you see, make sure you write another new prescription. Don't write on the same prescription. Otherwise, they will buy the same medicine one more time and go home. And another error in the vaccination. Whenever they come for vaccination, again calculate from the age whether the child is due for this vaccination and give. This error has occurred many times in the nearby hospital. So just add up on these 3 points, sir. That's all, sir.
Thank you, Lalit. I also just want to say that because it's better that we have a documented, better documented OP details with us. Because nowadays, even a death happened for a child, even when it is OP is audited in the government side.
Just one more point, sir.
Yes.
Sir, in OPD, you need to maintain an OPD register. According to income tax rules, you have to write the name of the patient, diagnosis, how much you charge for the patient in that register. Your auditor may say you just, which is, I think it's a form C something, form 3, that has to be written and kept it. It will be served for you for the income tax purpose.
Okay, thank you, Lalit.
Sir, so, 1 hour over, sir. There are 7 more topics.
Okay, sir. Thank you, sir. Thank you, please. Thank you. T.N. Manohar, sir. Whenever we write medicine, particularly paracetamol, I'm really worried whether they are going to get 100 milligram drops or or 120 milligram syrup or 250 milligram syrup or 500 milligram syrup, how do you avoid the errors, sir?
That's why we generally I keep a sample of all the strengths of the medicine on the table, as well as if I am going to prescribe one dry syrup, sample of that also I keep on the table and instruct and demonstrate which is a syrup, which is a drop, which is the strength of the medicine, how to give, whether you have to use a dropper or use a measuring cup which contains 2.5 and 5. And also I demonstrate them how to dilute dry powder.
Fantastic.
So in this way we can actually, even then some of them, if we say 0.5 ml, they give 5 drops. So I always pick up the dropper and demonstrate what is 0.5, what is 1 ml, and what is 1.5 ml, everything.
Thank you, sir. I think this list also includes the oral rehydration powder meant to be dissolved in 200 ml, meant to be dissolved in 1 liter.
Yeah, correct.
This leads to very fatal errors. Thank you very much, sir. It's a simple way to explain, to avoid errors. And this is from Amal Raj. Amal, quickly, can you explain, Amal Raj? 30 seconds. Can you quickly explain?
Sir, documentation
he's a rubber stamp pediatrician. So he utilized the rubber stamp in a very fantastic way. I was really thrilled to see that. Yes, Amal Raj. 30 seconds, Amal Raj.
Is he married?
Yes, thanks for the compliment, sir. Actually, this is basically because the documentation has to be very pakka, sir. The first one on the left-hand side is regarding the investigation we do for any fever on day, when it goes beyond day 3. This is from my brother, Dr. Payani Raman, sir. The advice which he has given me and I am following it so far.
Elder brother or younger brother?
He's always my big brother, sir. And the second one is for children who present with acute severe respiratory infections, sir. These 4 things will determine, sir: activity of the child, rapid breathing, feeding difficulty, sleep disturbance. If the child has any of these criteria, mostly I sound a warning for admission. The third one is to look for urine output and activity. The child is for any child with acute watery diarrhea, which becomes very clear to the parents. Actually, the message is very clear to the parents. And the fourth one which I put forth is for the 10 commandments, which for dengue fever, sir. If the mother we advise the parents to look for these 10 features actually, which is actually very easy. And my teacher, Tangul sir, has taught me always fall in the feet of the child when you see any child with dengue or any child with fever, look for the dorsalis artery pulsation. Teach those things also. How to look for the dorsalis pedis artery pulsation, and also how to look for the CRT, capillary refill time also. This has helped me a lot. And as you rightly pointed out, sir, regarding the ORS, I insist on buying only the 200 ml small sachet and never the 1 liter sachet. I have both, and I show the parents that never to buy a 1 liter sachet because the preparation can be a little difficult for the parents, and 200 ml sachet is very, very easy. And never to use the ready-made ORS liquids and all. Always follow the WHO hypoosmolar ORS solution, sir. Thank you.
Thank you, Amal Raj. It's very, very useful information that the ORS has to be properly explained to the parents. I think the 10 commandments helps right from the Old Testament days right to the 21st century. Thank you, Amal Raj.
Thank you, sir.
This is a prescription from Sunil. Sunil, can you take some 30 seconds to explain the prescription? It looks very legible, very clear, and every data is complete. Everything is complete. Can you quickly explain?
Sunil? Am I audible? Okay.
Yes, sir. Yes, sir. Sunil.
So, few things that MCA wants is they want address of the patients in the prescription. I know it's very difficult to write, but they want address. That is all. Then some vital signs. Most of the vital signs are recorded by staff nurse. I just measure the respiratory rate and blood pressure. I only take. So all this has to be there. And regarding medicines, they want the chemical name also. So you can see everything. There's some chemical name. And they want some local language also. That's what MCA wants. So you can't write the entire thing in Tamil, but at least some description is there. I think this is much easier for them to understand. Thank you.
Thank you. Very, very nice. You write both trade name as well as generic name.
Yes.
Thank you. This is the next prescription is written by me. I used to write as first. I always write the date instead of writing as for 3 days, 4 days, 5 days like that. Fever diarrhea from 1/7. The child has come to me on 3rd July, and then I quickly write is no vomiting, diarrhea 6 loose stools, urine 5 times, no cold, no cough, no urinary symptoms. This helped me in saving a lot of time. Temperature, I use a periodic Aspen triangle. It's very simple. I think it is very easy to use. Appearance, AVPU, A, child is alert, and respiratory rate and no intercostal retractions, and then pulse 100. 3 plus 2 is 3 plus 2, 3 plus and 2 plus is the terminology what we use in ICA. 3 plus for the central pulse and 2 plus for the peripheral pulse. Both are normal and hydration adequate. Coming back to the system and write a simple diagnosis. Day 3, fever and acute water diarrhea, no dehydration. I write the prescription zinc drops, ORS. Write this, I make a picture and tell the parent that 200 ml water you have to dissolve. Once I put the line up to this level, next time when the mother came and said she dissolved only in half tumbler, I asked her, why did you write half tumbler? I told you 1 tumbler. No, your picture said as half tumbler only. So that I was very careful to fill up the tumbler by lines. And then paracetamol syrup, and then write us to come back. A disease specific review. The urine frequency less than stool frequency, please come and meet me. Or the child looks tired, or the child stool shows blood. So this prescription is easy for me, it takes about 3 to 4 minutes. And I think as Sunil said, that these are all these points should be there in the prescription. Symptom duration, system involved. So because we are going to write only simple diagnosis, URA, LRA, sometimes there is no focus. We can even write as fever without focus. Vital signs of physiological status. Viral or bacterial is a key to decide whether we are going to use antibiotic or not. Working diagnosis, treatment, lab, and disease-specific review. I'll move this question to juries, Professor BRN, PRC sir, and BV for extra points.
The basic difference between a handwritten prescription and a digital prescription, and why I have been hesitating for quite some time, is eye contact with the parents. When you are typing the prescription, your concentration is on the computer. You are not looking at the parents' eyes, and they may not like it. If you have a person to type your prescriptions, fine. I think it is well taken.
Ravi.
Tangulu?
Yes, sir. Yes, sir. Please, sir. Please, sir.
The point has been well discussed, I think.
Yes, sir.
But VV said eye contact is less with these electronic devices. But I think there's some compromise you have to. Go ahead.
Thank you, sir.
PRC, sir. PRC say.
Sir, I do agree that electronic prescription makes it easier. But the other thing is, nowadays, more than drugs, many times we give a non-drug advice. So a few things, I mean, just note down, like giving homemade fluids and when to come back. Sometimes these things may not be available or may be available. I don't know. I have not used IAP, this thing. So to put whatever I require to give a non-drug advice also, it is easier for me when I write it down. So make it less drugs makes it easier for us to write the prescription much more legibly and also explain to the patient. It's a quite individual person's comfort.
Individual comfort, and it is at least for that say we can reduce the number of prescriptions. That's a good idea, sir. Thank you, sir.
10-second interruption, Thangavelu.
Yes, Sunil.
Printing takes 1 minute, writing takes 4 minutes. Thank you.
Thank you, sir. Thank you. Maybe it all depends on the comfort, I think. Comfort of the user. Yes, sir.
When you are writing, there's no eye contact also. Thank you.
Tangavel, sir.
Yes, sir.
Non-pharmacological advices, everything is there in the IAP
software.
Yeah. So we can just add, click and add. That's
okay. Yeah. It all depends on the comfort. Comfortable not, but I think both are good only, either handwritten or computer. We can't go for Solomon Papaya to panna mudiyadhu. But at least I think everybody individual comfort. Probably I will also one day I'll become Palliraman or Sunil Srinivasan. I don't know.
Now present generation are very tech savvy, sir. We can encourage the IAP software.
So I cannot detect 50 years from my age. Thank you, Palani. Okay. So now when we come to the important part, decision-making steps in office practice. Whatever we talk is a clinic, everything, this is a key. How we are going to assess the child, whether it's a stable child come for only a cold, or child has come with dengue shock, or the child has come with a very serious viral bronchiolitis. So I thought this is a very important question, decision-making steps in office practice. Because I start with Mahalingam sir. Sir, Mahalingam sir, I said, sometime your speed will be 25 per hour, Mahalingam, and see, we can't even cope with that. So how to balance fastness and accuracy, sir? I agree, fastness, at the same time accuracy. How do you balance both?
After such a long time of my practice, I think that you will all agree, once the child is coming inside our chamber, by the time we will assess that whether the child is in acute crisis or not. Sometimes, most of the time, that the patients will make a scene, but there may not be a real problem at all. The vital signs like a seizure, coma, respiratory rate, heart rate, and oxygen saturation, all these things will just go ahead. If needed, in the next chamber which I am having, where that staff nurse and my juniors will start doing that. And with a look on that, my boss, my professor, Dr. J. Viswanathan, used to train us only like that. Just to see that a child with coming to you with respiratory distress, what are the possibilities? More than that of a computer speed is we can assess really it is really critical or not. With
Thank you, sir. I think
we can assess that.
Okay,
Similarly,
thank you, sir. Yes, sir. Yes, sir.
So if at all that the child is, he used to tell that the child comes with that edema and all, and anasarca, something like that. You see, three things, most of the important thing is one is a cardiac problem or renal problem or in the liver problem. You just ask them to see where it is started. If it is periorbital, yes, you go down. It is from the lower down part, that is renal. If it is started from the lower limb, then probably it is from the cardiac. So within a matter of seconds, even from the history, we can assess that. And accordingly, you touch your hand, and then you can say it is really complicated, and even where we are, which system we are. So with our experience, we can easily point it out within 1 minute, sir.
Thank you,
so
sir.
The explanation will be take time. That's
Thank you, sir. I think probably this experience is being now provided by the PALS courses. PALS give us the way to assess the vital signs within 30 seconds or 1 minute. That is probably important asset we got from the PALS courses. So quick vitals and how to do symptom analysis, focus on infection. Can you do it simultaneously or sequentially? I will start with that Lalit. That Lalit, Satish and Amal, Arulal, a big list of clinicians are going to answer this. So I just want you to restrict only 15 seconds, Lalit, 15 seconds.
Whenever a child comes and sits in my table, just two things runs in my mind. It's a sick child or a not sick child. Not sick child, I do not break my head at all. If it's a sick child, for what complaint they say, according to the system, I go. Incessant cry, I just look for head to foot. Just look it in the ears, any pus coming out, in the eyes, any conjunctivitis. When the child cries, opens the mouth, look for any signs in the oral cavity. Like this simple clues will give us a clue what the child is having. These small things, and run the hand over the child from head to foot in a crying child. Small information definitely gives a lot of clues, sir.
Thank you, Lalit. Satish.
Yes,
15 seconds.
Sir,
only 15 seconds only.
Yes, sir. I recollect what you taught me, sir. Actually, I was coming to you in 1991 or so when I was.
I forgot that, Satish. Now you can teach me, please.
So, what you used to say that the McCarthy scale, that the well-being of the child as told by the mother and well-being as it appears to be, I think are the ones which will assign the level of care. The child needs OP care or admission. And that's one thing you decide. Second thing is as you said that the PALS course etc. have given objectivity and replace the subjectivity with objectivity, utilizing the interpretation of the vitals. I think I have the vitals already recorded in the case sheet and the prescription, and therefore we interpret these two things together. I send the level of care. Second thing is, okay,
yes, please. Yes, sir.
The second thing is, I think when we see the patient, I think if we see the patient for the first time, the patient should be seen like a long case where all aspects have been gone into. Now, regardless of the time, or at least some other time has to be granted. If that day the time could not be granted, I write down for detailed checkup next visit. Because so many times we have missed the undescended testes who comes for diarrhea 3-4 times. They would come respiratory infection 3-4 times. And so the certain things like ASD murmur, rickets, undescended testes
like-
are two
we are
subtle
likely to
things
miss. Okay.
which therefore we should not miss because they trust us and come.
Thank you, Satish. Now, sir, Virdagiri sir, 15
Yes.
seconds, sir. Can you briefly tell us?
The toxic look of the child makes the difference. How it looks. The child is toxic, then I focus on the systems. The child is not toxic, probably it's a trivial infection which can be managed without much botheration. And as all pointed out, the respiratory rate, pallor of the child, how the palm itself, just look at the palm, and the palm is pale, either it is anemic or suddenly there is a shock in the child. And feel the pulse lower down also. Respiratory rate we'll have to see. Is how I assess.
Thank you, sir. Thank you, sir.
Look at the child gives
Yes, sir.
toxicity of the child looks a lot of information.
Okay, sir.
Sir, just a couple of points to add.
Yes, sir.
One is that, I mean, we look for a sick child or a well child. The other point is, as everybody told, pattern recognition is more important. But one is what which we should know is what the mother says.
பிரியாணி கொஞ்சம் இருந்தது, அது என்ன பண்ணதுன்னு கேளு.
One part which we should never forget is what the mothers feel. If, in spite of however confident we are, if the mother feels the child is not all right, I think we need to still dig. I have definitely found a few instances where I was wrong and the mother was right. So that is something we have to keep in mind, sir.
Thank you, sir. Thank you. We'll end with Arulalan. Arul, 15 seconds, Arul.
ஒரே ஒரு பாயிண்ட் தான் சொல்றது சார். அம்மா வந்து குழந்தை தூங்கல, தெளிவா இல்ல, பால் குடிக்கல அப்படின்னு எனக்கு ஈவினிங்கே மெசேஜ் பண்ணி இல்ல வாட்ஸ்அப் பண்ணுங்க. லைன்ல பண்ணி கூப்பிடு, டாக்டர் பார்க்க போறேன்னு சொல்லிட்டு. தட்ஸ் ஃபாலோ அப் அஷூரன்ஸ், தட்ஸ் ஒன்லி வே பண்ணணும். பாயிண்ட் பிளாங்கா பேஷண்ட் கேட்பாங்க, சார் நீங்க பார்க்க முடியுமா இல்ல நான் சீட் போகட்டுமா?
அருளாளன் சார் கொஞ்சம் க்ளோஸா வாங்க சார், மைக் கொஞ்சம் க்ளோஸ் வாங்க சார்.
only thing is follow up assurance of follow up support sir. நீங்க வந்து என் போன் நம்பர் இருக்கும், ஏதாவது இருந்தா எனக்கு ஈவினிங் போன் பண்ணு இல்ல மெசேஜ் பண்ணு. கண்டிப்பா நான் மிஸ்ட் காலாவது கொடு. 3 முறை மிஸ்ட் கால் கொடுத்தா நீ ஏதோ பிரச்சனை இருக்குன்னு அர்த்தம், நானே திருப்பி கூப்பிடுறேன்.
Thank you, Arulalan. இது கூட கோட் இருக்கு போல இருக்கு. நான் ஒரு மூவில பாத்துருக்கேன், 3 தடவை வந்து ஸ்டாப் ஆயிடுச்சுன்னா வேற ஏதோ கோட் சொல்லுவாங்க. இதுலயே கோட் இருக்கு போல இருக்கு. Thank you, Arul.
Sir, just one point to add, sir.
Yes, Amal.
Yes, sir. Actually, what I do is, sir, any child who is above 4 years, என்னதான் parents complaint கொடுத்தாலும் கடைசியா குழந்தைகிட்ட நம்ம கேட்டுட்டோம்னா it has helped me a lot, sir. நிறைய டைம்ஸ் பேரண்ட்ஸ் மிஸ் பண்றதை குழந்தைங்க சொல்றாங்க சார். ஒண்ணு. ரெண்டாவது வந்து அந்த குழந்தைக்கும் நம்ம மதிப்பு கொடுக்குற மாதிரி சார். The child feels more confident. டாக்டர் நம்மளே மதிச்சு ஒரு கேள்வி கேட்கறாங்க பாருங்க, it gives more confidence for the child, sir. See,
எங்கே போயிட்டீங்க அமல்ராஜ்?
Thanks, sir.
சொல்லுங்க ப்ளீஸ் கண்டினியூ, ஜஸ்ட் ஃபார் ஃபன். சொல்லுங்க.
Yes, sir. அது மாதிரி it has helped me a lot, sir. நிறைய டைம்ஸ் வந்து பேரண்ட்ஸ் வந்து பிரமிச்சு நிப்பாங்க சார். என்னடா அது ஏன் முன்னாடி சொல்லவே இல்லை, இப்ப டாக்டர் கிட்ட புது பாயிண்ட்லாம் சொல்லுது. It happened even yesterday also, sir. So we should make it a habit that any child more than 4 years, we should talk to the child also. Childக்கும் we should give respect, sir.
Good point. Thank you. Palani, I just come back to you, but anyhow, key for deciding antibiotic is whether your thinking is viral or bacterial. Of course, we are not going to do a test. Only by clinical assessment. Can we do it easily?
Sir, can I just add one point, sir?
Yes, through.
I have a very simple test, sir. Or chocolate, I usually give dairy milk chocolate to every one of my patients, sir. So if the child asks for me, or if the child is really reaching out, that really tells me that the child is not sick. It's a very effective way of finding it. Of course, costly way, but it's effective, sir.
So we label as dairy milk test. Dairy milk test. Okay, thank you, Thiru. Palani, solunga, viral and bacterial.
Sir, ரெண்டே point, only 2 points. If the child is very sick or toxic, it is indicates serious bacterial infection unless proved otherwise. Number 1, serious bacterial infection, head to foot meningitis, pneumonia and pyelonephritis. This is more than commonest bacterial infection. Number 1. Number 2, if the child is having fever and localized problem, it indicates benign bacterial infection. For example, cellulitis, lymphadenitis, all bacterial infection, it is localized along with the fever. But whenever there are multiple symptoms from the head to foot and multiple signs, it is viral. And multiple members in the family are affected, viral. And the whole community is suffering, it is viral. So this is the way easily you can differentiate. Just 2 things. Sick child is serious bacterial infection unless proved otherwise. And any infection, it is a localized, it is always bacterial. When it is a generalized, it's mostly a viral. This is a grossly, we can easily come to conclusion.
Fantastic.
One more point, viral.
Okay. Probably one more point.
Yes, sir. Yes, sir. Please, sir.
Is it an acute onset or an insidious onset?
Okay, sir. Okay.
Viral infections are like accidents.
Accident.
Child goes to the school, even it comes with fever.
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. Agreed, sir. Sir, Manohar, sir. TN Manohar, sir. Sir, Bridhagiri, sir, we want to tell anything more, sir?
I said if it's an viral infection, the child will be abrupt onset of the symptoms.
Okay.
Like the child goes to the school or sleeps in the night, morning the child is found with fever. Whereas in a bacterial infection, it's more often a insidious or 1 or 2 days or time interval is there.
Thank you, sir.
And a very one important point in the history, mother says is in between fever or after paracetamol, the child is playing around. It indicates mostly you're dealing with a viral. Even in between fever, the child is not doing well. It indicates mostly bacteria. This is third point.
Interfebrile state. Thank you.
Yes.
Manohar, sir. TN Manohar,
Yes,
sir.
sir. Yes, sir.
Red flag signs. Sir, how do you teach us how to?
Yeah,
recognize
already clinical findings Dr. Amal Raj has displayed and others have told. The only thing I ask the parents is the intake, activity, and behavior during an illness. If during an illness, if the child takes food at least to some extent and they're able to play between fever, or during an illness other than fever, if they are able to move around and behaving, answering relevantly, it's a mild illness, we can treat at home. If any child becomes lethargic, refuses feeds, and behaves abnormally, then they should immediately rush to the hospital. And all others told, during a fall from height, if the child loses consciousness or throws a fit or has persistent vomiting, once or twice vomiting does not matter. If the child has persistent vomiting and becomes lethargic, they should rush to the hospital immediately. During a diarrhea, if the child is not voiding urine for more than 6 hours or not refusing feeds or has persistent vomiting or the tongue becomes dry, then they should rush to the hospital. These are some of the additions.
Okay. Thank you, sir. Thank you, sir. Very brief and crisp one. Mahendra, can you quickly sum it up, the whole thing in 30 seconds? In bullet points.
In a total of 6 to 8 minutes we spend with the patient, we can divide into 3 portions. One, we take a history and examination for 2 to 3 minutes, 2 minutes for prescription writing, and 2 minutes for counseling. Here we have to examine and take a history simultaneously. As a patient enters, you assess the ABC, whether the child is active or sick, look work of breathing, and check for the dorsalis pages and peripheral temperature. So, for example, in dengue season, as you're asking the history of when did the fever start, you can start touching the feet of the child, assess work of breathing. So examination and history taking can happen side by side. After that, you look for focus of infection, whether you have a septic focus like a tonsillitis or a skin infection. So with that, you can conclude into either of the 4 situations where one, you have a simple viral illness, you reassure and send the child, or you have a child who has lots of issues like you need to have symptom relief medications. Some situations you have to write an antibiotics. So that's a second scenario. Third, you have a scenario where you have to investigate and decide. That's the third scenario. Or if you have any abnormality in ABCs, any abnormality in airway, breathing, or circulation, you have to refer. So the important point is history taking and examination happen side by side in a clinical setup.
Thank you, Mahendra. Super sorry. 8 வருஷம் பிரிச்சு ஒரு பாட்டு இருக்கும் பாட்ஷால மாதிரி 2 நிமிஷம் 2 நிமிஷம் பிரிச்சிட்டீங்க 8 பிரிச்ச மாதிரி 2 பிரிச்சிட்டீங்க நீங்க. Thank you, Mahendra. So from my experience, I just put the differential diagnosis for fever of less than week or less than 5 days. 80 to 90% benign viral infection, where we may not be doing much except paracetamol and giving the warning signs. Then comes acute bacterial systemic infections, skin infections, or upper respiratory infections, or pneumonia or UTI. And third group comes as tropical infection, dengue, typhoid, and strep typhus. Last one in non-infectious. Recently we saw MIC and Kawasaki. How to do that? Step 1 is check the vital signs. Mahendra said, very nicely said, check the ABCs. That's very important, or by pulse. Second step is whether viral or bacterial. Third step is you look for the focus. What do you mean by focus? When I just started reading, I couldn't understand what is focus. Focus means any clues which is suggesting that this may be a respiratory symptom involved, like throat pain or tonsillitis or tachypnea or cough or skin and soft tissue infection or abdominal signs, hepatosplenomegaly, maybe indicate your tropical infection. If we don't find any focus, more likely to be a simple viral fever or urinary tract infection. This is what we meant by focus. This is a video recorded in my clinic. I think every child coming to my clinic, whether it's URA or LRA, whatever it is, I don't ask the question first. When a child comes inside, I just assess the ABC as per the pulse. This helped me a lot to identify a sick child from well child. This doesn't take much time. This is a video recorded in my clinic. And I got a consent from the parent who is a pharmacy person nearby. Child looks conscious because got a good eye contact. So A is alert. I tell them to remove the shirt before coming inside. Child responds to my sign. Again, it's alert. Child gives time for me to count the respiratory rate, look for any retractions. I don't hear any noisy breathing, no retractions. I could count the respiratory rate, came to around 32. Simultaneously, draw the attention of the child and check the dorsal respiratory pulse and capillary pulse. A, B, and C. Everything looks okay for me. This is so 30 seconds time I could assess the ABCs, alert child, and no tachypnea, no retractions, good pulse volume, good capillary refill. 99% of the time, this child may not recover any investigations or any hospitalization. This gives me a lot of reassurance, and then I go for the other things, looking for the focus. This is shared by Dr. Arulalan. So this is a very important point he has told. Even in the waiting room, they can look at this. Eppa avasarama hospital varano. தூக்கம் பாதிச்சிருக்கு அல்லது ஃபீடிங் பாதிச்சிருக்கு அல்லது தெளிவில்லாம இருக்கு, கான்சியஸ்னஸ் சேஞ்ச் இருந்ததுன்னா immediately come to the hospital. A very good simple advice. தூக்கம், level of consciousness or activity, and then feeding. If it is affected, they have to come to the hospital early. Suppose ரொம்ப waiting roomல நிறைய crowd இருந்தா கூட they can tell this and convince the receptionist and gain entry into the hospital. So this way, probably this post will be very, very useful. Thank you, Arulalan. And he's a person who taught us the Semmelweis, who taught us the hand washing technique very early, even 200-300 days ago. He taught this even before the microbe concept. So unfortunately, he died for his cause of what he wanted to spread the concept. Everybody did not agree with him, and he was assaulted by a security staff, and then he died. He died for the cause of hand washing. After his death, only people realized that microbes is a reason for infection. The hand washing helped everybody very much. Thanks to Semmelweis, who promoted the concept of hand washing. I salute to him. The juries, Biaran sir, Biar sir, and VV. About identifying sick child.
Yeah, I think all the points are well covered, sir. So right at the time the patient comes in, have an observation. When you are asking the mother's history, you look for the red flag sign or the symptoms as mentioned by her, which are Arulalan also explained. And thirdly, you do a rapid examination. Pulse helps you in that. So most of the time, you will be able to come to a conclusion based on this.
Thank you, sir. So, Biaran, sir.
As years goes by, with more and more experience, you develop the intuition. I also working in children's hospital, attending OP there, seeing about 100 patients in about 1 or 2 hours, it helps you to develop your intuition to recognize a seriously ill case or not seriously ill case. That's one thing. The second important thing is I remember Dr. Balagopal Raju, what Dr. Amarlaj said. He said, yeah, Dr. Balagopal Raju tell us, take the child by the hand, I will get the mother by the heart.
Fantastic, sir.
So we should think of a different way also, but as it is, it means a great thing. That's what Amarlaj said. Okay, nothing more for me to add.
Thank you, sir. VV, sir.
Yes, one more. Identifying a sick child, a well child is fine. But if we hurry through the well child examination also, Like Dr. Satish rightly mentioned, we can miss undescended testes. It happens that you can miss a choledochal cyst, but failing to note a mild distress in the child, which otherwise looks normal. So, identifying a sick child and a well child is not the only thing. Whether you're going to diagnose a thing in a child or not, the parents would have come for some other complaint, leave alone the viral and bacterial infections, which form 80% of our cases. But identifying a point which is missed by so many is possible only when you spend minimum of 8 to 10 minutes per child.
Thank you, sir. I understand and agree, sir. We ask the concern of the parents and then focused examination probably will bring out. And a good complete clinical examination. At this point, thank you, sir. Thank you. Not the pulse alone, it's not. Pulse is only the entry pass. I take this opportunity to tell all the viewers, all the senior pediatricians, pulse course almost revolutionized the way we manage the emergencies. Of course, if pulse does not teach us the routine concerns like undescended testes or hernia or other things. So it's very, very useful. So I request all even the seniors to undergo the pulse course. Everybody is afraid of pulse course because there is an exam there. So it is not a pediatric advanced life support. It's not going to teach us something advanced. But PRC used to say that advanced does not mean that pulse is going to teach you advanced things. It's something like high school. High school is not equivalent to PhD. They're not teaching anything high, very high. Compared to the primary school, it is a high school. Similarly, compared to BLS, it is an advanced course. That's why it's called a PALS. Now the PALS group has come up with a very simple via media for the senior pediatrician. There's a course called the MAP course, where you can just get sensitized to the PALS concept. There is no exam. This exam is a really big attraction for all of us. Any senior can undergo that course called the MAP course, Mass Awareness Program of PALS courses, where they need not write an examination, but they will be given a certificate. They will know all the concepts of PALS course within one day. Thank you, sir. With this, we will move on to the next question. Sir, ordering the lab test.
1.5 hours over, sir.
Okay. Yes, sir. Sir, hereafter we will behave like Mahalingam sir and Palniraman sir. We'll go faster.
6 more topics, sir.
Okay, sir. So the lab order, out of 10 patients, how many may have how many you order lab test? So I reduce the timing, answer timing to 10 seconds, sir. Lalit, how many patients will order lab test out of 10? Quickly.
Mostly out of 10 out of 10, no lab test, sir. Maybe 1% may be needing a lab test.
Mahalingam sir.
Generally, sir, as you already mentioned, once the chest is clear and no relevant complaint towards the respiratory or cardiac, and most of the time we are likely to miss is urinary tract infection. I always tell my juniors, once that lungs is clear and no focus where we are able to see, kindly rule out the possibility of urinary tract infection. Okay, and at the same time, examine the abdomen. If there is a hepatosplenomegaly, something like that, and they are coming from, for example, from Ramnadi for our side, probably we are dealing with a case of malarial also. And we may not have the clear-cut classical features as in that of adults, chill and trigger and everything, it will take longer time. So that may be giving you a clue. So we will go for urinary tract infection. Very often we are likely to meet the tract.
Thank you, sir. Look for the clue. Even if it is no clue there, probably you look for UTI. Thank you, sir. Sir, Selvan, we have been silent for a long time. Selvan?
Yes, sir.
Out of 10 patients, how many will write a lab request?
1 or less, sir.
1 or less. 1 by 10 or less. Commonly, what is the commonly written lab test for fever in your practice?
The first 2 days urine examination, followed by complete hemogram, sir.
Okay, complete hemogram. Okay, sir. Simple test, but quite useful. Okay, sir. And what day of fever you will order for the lab test?
From the day of 3, sir.
3rd day only. Day 3
but
is the most
if
important.
The mother says that the child is unusually quiet and not active, she is not like previously, I will do the test yearly.
Okay, sir. Okay, sir. Thank you. Thank you. Day 3 or even earlier, if you think the child is sick, either by assessed by parents or ourselves. Amal Raj, out of 10, how many lab requests?
Yes, sir.
What day? What day? What lab?
Usually day 3, sir, depending upon the sickness of the child. If the child is sick, usually on day 3 I do. Basically, I do CBC, CRP and urine routine, sir. Dave, any fever more than 6 days, I usually advise hospitalization, sir, to be on the safer side, sir.
Thank you. Arlalan. Arlalan, sir. Keep the mic closer to you, sir.
72 hours தாண்டா தான் டெஸ்ட்டுக்கே போறது. Only urine test, sir. 1 out of 10, sir.
Okay, okay, sir.
Urine, sir.
Okay, sir. Thank you. Thank you. I think all of us agreed that by first 3 days, nothing is needed except the child is sick. Otherwise, generally we do it on 3rd or 4th day. But infant and toddler, we have a low threshold for the laboratory test. Thank you. This is just to show an example that the urine test is one of the fantastic test. Fantastic test. A simple urine test showed about 20 to 25 pus cells. And then hospitalized showed a high CRP 116. Culture showed E. coli. He has a sensitivity pattern. So it started with a very simple test. Simple test led to a big diagnosis. So it's a very, investigations are quite useful, particularly urine test, simple urine test. If it is done properly, urine microscopy will lead to very big diagnosis. Thank you, sir. From this, I just, what I do is by 3rd day, I do the CBC, CRP, NS1 antigen with urine routine. This will tell us whether it's a bacterial or viral. CRP is less than 20 viral, more than 40 is bacterial. And CBC also will give an idea about viral or bacterial. If it is viral, whether it is a dengue or non-dengue, so NS1 antigen is done. Urine routine is identified by the presence or absence of pus cells. On discretion, I ask if the parents are affordable by 4th or 5th day they comes, I order for blood culture to identify typhoid. And the child has got cough or tachypnea, I order for chest X-ray. The first basic test costs around 1,500 rupees. The on discretion is a broader test costs around 2,500 rupees. This also counts. And if the child comes with the tachypnea and cough, this was taught to me by our teachers, Professor BRN, Professor LS, and all the teachers. If you order for an X-ray test, it is our duty to see the X-ray test within 1 or 2 hours with film, or at least on the same day. If you order for NS1 antigen, better to collect the NS1 antigen the same day itself. Otherwise, probably we lose a sick child. And we use this simple algorithm. If the child has got a negative CRP and there is leukopenia, it's clearly viral infection. Leukopenia means less than 5,000 WBC count. So based on WBC count and CRP, we can categorize into 4 common illnesses. Negative CRP, leukopenia, viral infection. Negative CRP, leukopenia, but high PCV, low platelet count, and NS1 is positive is dengue. But third category is high CRP and high WBC is mostly a pyogenic infection in the skin, UTI, pneumonia, meningitis. High CRP with a low or normal WBC count, invariably with enteric fever. We are seeing it's very highly correlated with the culture positive salmonella. These 4 categorizing possible if we do the CRP and WBC count and NS1 antigen. And I asked juries and other faculty to comment about this 5 categorization. Do you feel it is okay or?
Agreed, sir. Nothing to add.
Fully agree.
Okay, we'll move on to the next question.
Only one thing to add on.
Yes,
I think we should encourage parents to plot the temperature in a paper and bring during every visit. Okay. That helps us to decide whether it's a decreasing trend or a worsening trend on day 4.
Good. 2 youngsters, one believe the parent, another believe the child. Nice. Amal Rajan and Mahendra. Thank you. So there are a lot of people which I discussed earlier itself. They never thought about themselves. They thought about the public health and patients. Madam Shanta, madam, and she said, sprinkle my ashes all over the Cancer Institute. That is her last wish. Who fought for the children or adult with cancer. I think along with Muthulakshmi Reddy, they initiated the Cancer Institute in Chennai. We salute her for all the nice thing done in the form of Cancer Institute. I just want to list to the viewers that among us, we have so many nice people who are great people who lived along with us. We'll move to the very important concept, antimicrobial stewardship. In every 10 patients, how many may receive antibiotic? Quickly, again, I reduce the timing of answering because Vijayaragan will not leave me alone. So please, Satish, 10 seconds. In every 10 patients, how many receive antibiotic? What is your antibiotic choice? Different infections.
Yes, I give just
10 seconds only, Satish.
Yes, sir. Yes, sir. 1 out of 10 only a child may qualify for antibiotics. And usual things are diarrhea, upper respiratory infections, skin soft tissue infections, newborn with either fever, either spurious fever, yellow fever, and fever without focus. So in all these cases, in fever without focus, just differentiate between viral, bacterial, and try to see if there's no focus, no bacterial focus, no prescription of antibiotics. Counseling the parents that wait for 48 hours, third day you call me. I give a specified time for them to call me. The second thing is in a newborn, if it differentiate between spurious fever and real fever from usual criteria, and then strip the child and then keep the baby under the fan for some time to see if the temperature cools off without any administration of medicine. Thirdly, if it's skin and soft tissue infections, if it's local infections, no topicals, or if it is something like impetigo, which is extensive, we may give oral antibiotic like cefalexin or amoxicillin.
Thank you.
If it is pharyngitis, use a Centaur score to decide whether to antibiotic to be given or not.
Thank you, sir. Selvan?
Sir, already answered, sir. Antibiotics are probably, if it is a viral, no antibiotics. Bacterial, as Dr. Satish has informed, sir. Nothing.
Yeah. I think probably next question I will ask Selvan first and then go for Satish. Satish, tell all the answers. Thiru?
Sir, not more than 1 or 2 per 10 patients, sir. Maximum 1, sir. Romba rara 2.
So all the 10 will get chocolate, but only 1 or 2 will get antibiotic. Correct?
Yes, sir. Definitely, sir. Sir, not only the chocolate, the other kids also come. They also get chocolate, sir.
Oh. Thank you. Do you have a chocolate industry?
No, sir. I spend a lot of money on the chocolates. It makes them happy, sir. They are very cooperative for the examination.
Okay, great.
So auscultation is a lot more easier.
Okay, sir. Antibiotic decisions, I will ask Palani for the gold standard. What does the IAP says? Then we will come back to the antibiotic. Or I will complete the question here and then I will come back to Palani. Yes, mother bringing the child and the third day of fever, she's requesting, please write antibiotic. Insisting. This question I want Lalit and Mr. Mahendra to answer. Satish already told answers. I will ask Lalit first and then Mahendra. Mother is insisting, day 3, my child fever will not subside unless you give antibiotic. Please write something.
Try to convince the mother that there is no focus of infection. As there is a viral epidemic and viral infection signs are there, we will wait or we'll do a blood test or an urine test on day 3. If that shows some positivity, then we'll start an antibiotic. Unnecessary antibiotic will not help the child. I just try to convince the mother, sir.
Thank you, Lalit. Mahendra has got some novel idea to curtail antibiotic
This
use.
is not novel, so it's being practiced in some countries. I have a poster in the waiting hall about antibiotics and its abuse and its risk factors. 1. Number 2, sometimes I write an antibiotic for people who come from faraway place. Suppose if they come with a diarrhea, I'll say, use this antibiotic if you see blood in the stool or worsening fever and mucosy diarrhea. I write and say when to use it. So many times I have seen when they come for review, when I ask them, have you used it? They say they have not used it. So that gives them a comfort that they have a weapon in hand, but they don't use it.
Very nice concept. Thank you, Mahendra. And now I come back to Palani. Palani, you can tell what does the IAP says about antibiotic use and gold standard.
Coming to antibiotic usage as such, whether you see actually totally 50 patients per day or 100 patients per day, it's only a first and matter of attitude for excellence for doing the good thing for the patient, sir. That decides your antibiotic usage, not all other things, not the knowledge or not the thing. Your attitude for doing a good thing to the patient matters with respect to antibiotic usage. Number 1. So hardly 10% may need antibiotic. As everybody told, hardly 10% of your patient may need antibiotic. So these are the basic things IAP suggests. Any sick child, definitely no need to hesitate using antibiotics. Sick child is serious bacterial infection in pediatrics unless otherwise proved. Number 1. Number 2, coming to the respiratory infections where the antibiotics are used right and left. So common cold, we know viral. Only when it is a complicated cold, use antibiotic. Otherwise, don't use antibiotics because we know cold will run for 2 weeks and no need to reuse antibiotic. So only when it is complicated by otitis media or sinusitis, use antibiotic. In the same way, cough is a bronchitis, viral bronchitis, no need to use antibiotics. Unless it is a complicated cough in the form of pertussis, you should use antibiotics. We all know fever and fast breathing is the mantra particularly for the WHO, UNICEF, everything says it's an indicator of pneumonia. Pneumonia, no, definitely we know we use antibiotics. So with respect to respiratory, these are the things. Coming to the fever, fever is the only area where antibiotics are again much overused. Unless you know the focus, don't use antibiotic. You know it is a fever with pharyngitis, fever with cellulitis, fever with lymphadenitis, to start antibiotic. If you don't know what you are suffering, the child is suffering from, don't use antibiotics. Try to localize clinically or try to localize by investigation. Investigation by doing the urine test, you do the urinary tract infection is picked up. Sometimes you do by X-ray and occult pneumonia is picked up. These are the two common occult things. Occult UTI and occult pneumonia you have to pick up by investigation. So fever without focus is a common thing, and we have to pick up the occult infection either clinically or by investigation. Then you start the antibiotic. More than fever, more than 1 week, you are justified in starting anti-scrub typhus now treatment, which is the present day scenario. And if the 48 hours no response, you are justified in using empirical anti-inflammatory treatment. So coming to the loose stools, we all clearly told only when there is a visible blood and mucus, you should start antibiotic. So coming to the benign bacterial infection, we all know we are going to use antibiotic, which is a localized infection. So there is no point in the statement of to prevent the secondary infection, I'm using antibiotic. This is a useless statement and which is to be avoided. So clear cut, any serious sick child, use antibiotic. In respiratory, we know complicated cold, complicated cough and pneumonia, use antibiotic. In a loose stools, dysentery, use antibiotic. Fever, either you localize clinically or by investigation, then use antibiotic. Except for this, there is no indication for using the antibiotic in a well child. Exceptions are there. Finally, boiling down to just 3 antibiotics in office practice, 3 or 4, above the diaphragm or the respiratory infection, whether otitis media or a pharyngitis or a pneumonia, simple amoxicillin 40 milligram per kg for a period of 5 to 10 days, depending upon the situation. For example, upper respiratory tract infection, you should use for a prolonged duration because the organism eradication will take time. So this is the contrary. Upper respiratory infection used for 10 days, lower respiratory infection like pneumonia used for 5 days. This is the contrary. You always remember. Coming to the below the diaphragm, used mainly for the dysentery, used for 5 days, as well as you for a urinary tract infection. The cefixime usual routine dose of 10 milligram per kg, whereas in case of typhoid, see to that you are using a 20 milligram per kg for a period of 10 to 14 days. Coming to the skin, and third group is the skin and soft tissue infection. Simple cephalexin and cefadroxil are the drug of choice, not amoxiclav. So simple cephalexin, cefadroxil is enough. Rarely nowadays we come across scrub very commonly. Doxycycline is a drug of choice. Apart from these 4 drugs, we rarely need antibiotics in our outpatient practice. So above the diaphragm, amoxicillin or amoxiclav. Below the diaphragm, cefixime. Even though nowadays UTI, the chances of ESBL are more. In 48 hours, the child is not responding to cefixime. Think about ESBL organism, which is growing in the community. Coming to the skin, I've already told first generation cephalosporin. Coming to the atypical organism, doxycycline, azithromycin. That's all. Thank you.
Thank you, Palliraman. All the viewers, all the young viewers, the faculty who are talking to you are almost Sachin Tendulkar's, Dhoni's, and I don't know whether we can include Virat Kohli in that list also. They're all playing double centuries. They see 100, 200 patients. If they are restricting to only 10%, out of 10, only 1 they are writing antibiotic. This is a wonderful message. If at all, if you want to carry from this CME, I want you all to carry this. It's fantastic message from all the seniors. Thank you so much. So this is what I just, if you say 100 patients, I don't know, others will agree to this, but 60 to 70 patients out of 100 in OP practice, no investigation, no antibiotic, probably will give paracetamol and tell them the warning signs, lethargy, breathing difficulty, reduce urinary rashes, come to you, maybe dengue. Second group is about 20 out of 100. Do investigations, no antibiotic, give paracetamol. Probably if I think of UTI, I will do that. If I think of dengue, I'll do investigation, no antibiotic, I'll give only paracetamol, ask them to come with investigations. No investigation, but I will prescribe antibiotic if I identify a skin infection or otitis media, tonsillitis, or dysentery, blood and mucus in the stools. These are all clinically identifiable without any infection. I will use antibiotic without any investigations. How to hospitalize a child might happen only maybe 1 per week, 1 per 100 patient only probably in OP practice will hospitalize. Very rarely, once in a year, probably you may see a child with sick child with shock or severe respiratory distress, hypoxia, which may need to be shifted immediately by ambulance to nearest hospital. If the ambulance are not available, on one occasion, I just went the child along with the child in an auto, carrying a bag and mask and with oxygen, just carrying not an auto in a car. I went along with the child. If something happens, at least we can help the child till the child reaches safely to the nearest emergency room. This is what generally a spectrum of choices we see in our OP practice. This is one study done in BMC Infectious Diseases journal, where they have identified that same voice, same like all the faculty experts, only 5 to 10% may require antibiotic in our OP practice. 90 to 95% may not need antibiotics. A very, very good message brought from this journal also. It is done in Delhi among the private practitioners. They identified that 39 to 40% of the patients that visiting private clinics were prescribed antibiotic, but who may require only 5 to 10%. This is a lesson we should learn. Moving to juries, sir, BRN sir, PR sir, and VV.
All the points have been well described. Better to put a diagnosis also, even if it may not be accurate. You can put a suspected enteric fever or suspected urinary tract infection, so that you can just think whether you need an antibiotic or not, pending the investigations. So that will also be sometimes helpful. And as I've already said, one can definitely use the clinical judgment. Most of the time we can.
Thank you, sir. BRN sir.
Sir has some work, sir. Yes, excuse me.
Okay, sir. BB sir.
Treat the illness, not the parents or the child. Treat every child as if you are treating your own child or grandchild. That is the message I would like to.
Sir, ஒரு சின்ன ப்ராப்ளம் வருமே சார், ஃபீஸ் வாங்க மாட்டோமே நம்ம சன்னிட்டையும் கிராண்ட் சன்னிட்டையும்.
அவங்க கொடுக்காட்டா நானும் கேட்க போறது இல்லை சார். இப்ப கூட
ட்ரீட்மெண்ட் தான் சொல்லிருக்காரு, ஃபீஸ பத்தி பேசல.
இல்ல தப்பா நினைச்சு கூட அதுல யாராவது
இல்ல அவங்க கொடுக்காட்டா கேட்கறதும் இல்ல சார்.
Okay sir, thank you sir.
So can I have a small word?
Yes, so, we can have a big word, no problem.
Whenever we write an antibiotic, I think we should justify the reason behind it. As sir said, put a diagnosis. If your diagnosis is not clear, still we should put a reason why we are writing an antibiotic. And second, it's more time consuming to counsel a family to avoid an antibiotic than to write an antibiotic. So we have to take the extra step to talk to the family rather than writing an antibiotic, which is faster.
To save 2-3 minutes, we write antibiotic. Like most of us.
As Mahendra said, sometimes this is called deferred antibiotic. You just write it, but tell them that not to use it, and you can even write down the instructions when to use it, or tell them to get in touch with you by phone before starting an antibiotic. All this sometimes, most of the time, will obviate the need for antibiotic.
This is a very approved practice in many developed countries, sir.
Nice guidelines.
இதுல கூட பாத்திருக்கேன், செட்டிநாடுல சொல்லுவாங்க, பையனை வந்து செலவு ரொம்ப குறைக்கணும்னு சொன்னா கையில 1000 ரூபாய் கொடுத்துருவாங்களாம். நீ பார்த்து செலவு பண்ணான்னு சொன்னா செலவழிக்க மாட்டாங்களாம். Because he has money with him, every paise will count. He don't want to spend. Probably it's a nice concept, which is new, which I learned from this CMA. Thank you, PR sir and Mahendra. We'll move on to the next question. Fever medication. This is one of the commonest medication we prescribe in OP practices for fever medication. A child comes with high-grade fever. This is only first day fever, 5-year-old boy. And the mother says that my elder sibling had febrile fits. Do something, please. Give some powerful antibiotic. I can't tolerate this fever. Please, what is your choice? Will you write paracetamol alone and try to convince the parents, or go for NSAID like mefenamic acid, ibuprofen, Selvan? Probably.
Yes, sir.
Well, this parent is from Erode and coming to you.
So be sensitive to their concerns. Since they had a first child with fits, they will be more worried. Always make an entry in the case sheet that the elder sibling had a febrile fit. Tell the family that there is no evidence that prophylactic medication do not prevent febrile fits. So first, take into your confidence. My first drug and only drug will be paracetamol at the correct dose of 15 milligram per kg per dose. Tell them that paracetamol will not make the child afebrile, but it will make the child better. It will reduce the discomfort and the pain. If the temperature is more, I'll ask them, apart from giving paracetamol, they can choose other drug like ibuprofen only when they had used 4 to 6 times the correct dose. That ibuprofen is also should not be used when the child has a fever with vomiting or with the lower GI symptoms or not taking any drugs. And we have to tell them this ibuprofen has got side effect of allergy and gastrointestinal symptoms. Make a mention in your case sheet if they tell there is some family history of allergy or the child has some allergy to any other drug. Instead of ibuprofen, many of the pediatricians are now preferring mefenamic acid because of the easy availability and easy controlling of the fever. But remember, mefenamic acid is not recommended below 14 years of age. It does not have a legal standing if there is a problem and you end up in a consumer case. When I checked up the BNF, there are 69 side effects, right from anemia, agranulocytosis, DIVC, heart problem, dyspnea, renal and hepatic and CNS problem, including aseptic meningitis, tinnitus, vision problems, vertigo, and Jesus. So if you just read that, you will not touch the mefenamic acid in your lifetime.
Thank you, Selvan. After hearing that 69 side effects, the family took a taxi and came to Dindivanam to see Palniraman. Palniraman, நீங்க எங்க CME போல அன்னைக்கு வந்து கிளினிக்ல இருக்கீங்க. So what will you do?
Sir, I actually agree with Selvan. Nothing but paracetamol, only paracetamol. There is no evidence for mefenamic acid. Evidence is there for brufen, but it is because for the Western world they don't have mosquito-borne dengue, etc. We have all sorts of nonsense dengue, etc. So definitely even brufen, I won't agree with the brufen. So only paracetamol, nothing more than paracetamol I will tell.
Thank you, Palniraman. My dear friend Sunil, நான் எக்ஸாம் பாஸ் பண்ணதுக்கு சுனில் தான் ரொம்ப முக்கியமான காரணம்னு சொல்லுவேன். சுனில், நீங்க how about your mefenamic acid use and brufen?
Sadly, I was using it quite a lot in the earlier years of my practice, but for the past about 8 years, nothing except paracetamol works well for me. Thank you.
Thank you, Sunil.
Sir, one more point.
Yes, sir, please, sir.
In addition to the paracetamol alone, I will ask them to have an environmental cooling, in the sense remove the shirt. And one more thing I have practicing is rose water or the paneer. You ask them to spread all over the body, like painting under a fan or under the well-shaded place. That brings down the discomfort and the temperature also, and it gives a good cooling and a comfort, a good aroma also.
Thank you, sir. Non-pharmacological measures. And non-pharmacological measures, I have two problems, sir, because I don't encourage parents use non-parent, because dengue season, they literally soak with water. And whenever you touch a child will be cold. I tend to, and even pulse will not be felt very well. I tend to diagnose more dengue if they apply tepid sponge. That's one reason. There's also recently done a study in CMC Vellore. They have clearly disproved that tepid sponging does not reduce the temperature. But as Sir said, exposing the child, like removing the dress, keep under the fan or keep in a 25 to 28 AC room and all, probably will definitely be helpful to do that. This is one study done in our hospital, and one of our nephrology PG presented this. Nephrotoxic medication used in hospitalist children, and presented in one of the conferences. And there is about 2% of them had acute kidney injury, and all of them received nephrotoxic medication, which also include NSAID. And if that's almost 20% of the NSAIDs are used in the medication used in the OP practice also. And definitely the NSAID has some big issue with related to kidney. I think it's safer to stick to paracetamol. As I also fully agree with Palniraman, because whenever in the presence of all the tropical infection, even ibuprofen prescribed in US and UK may not be suitable in a place where they're endemic with all the tropical infections. Sir, PRC sir, your opinion. Followed by BB.
Sir, I do agree with already expressed this thing. So most of the times we don't need anything other than paracetamol. In my practice, I have never used any other drug. I have used only paracetamol. Especially keeping in mind, though ibuprofen is quite effective and probably longer duration, our special problems already mentioned by Dr. Pavitra. Regarding paracetamol, one has to be very careful choosing a correct formulation, documenting it, explaining to the parents what can be expected of it, and telling them when to come back regarding this non-response to fever or any other thing. So that has to be explained to the parents.
Agree with Paniraman as well as Sunil Srinivasan. Once upon a time when I was in my 30s, I've been using ibuprofen. But after seeing a child who underwent tonsillectomy, developing a torrential bleed, and after seeing a child developing a renal failure, which has been treated as a rheumatoid arthritis in another nursing home in our hospital, and seeing the child dying of renal failure, I decided I will not touch NSAID. So after the age of 35, I have never prescribed an NSAID for fever. I've been using only paracetamol.
After age of 35, sir, how many years you have not been using NSAID, sir? I just want to know your age. I just want to know your age.
No,
That's why.
35 years.
70.
So, all the young viewers, you need not wait till 35 or 40 to stop using NSAID. Right from younger days, even at 25 you can use it, because you need not come to that conclusion after 10 to 15 years. So you can right now itself, you can restrict only to paracetamol. Agreed, sir? All the seniors advise.
Experience is a comb that you get after you become bald. It is no more useful to you. It is useful to others.
Useful to be the visa, sir.
Thank you, sir. Thank you very much, sir. Now move on to the.
Sir, 2 hours over, sir. Can we ask for extra time? There are 2 more topics.
We have only 2-3 questions, sir. We'll finish it off because this is only part 1, sir.
So
I want to go for part 2.
Yeah,
We'll proceed, and another 3 questions only we'll complete, sir.
Yeah, we'll finish up.
Now, I think telecounseling was widely used during the COVID season. Widely used. Now, telecounseling usage has been more restricted. But Sunil feels that telecounseling has got a lot of usefulness, particularly to explain about the chronic illnesses, follow up the child. First time you can see physically and then follow up with telecounseling. And also to explain about investigations. So I request Sunil to talk about the telecounseling, what all the pros, advantages he encountered by using telecounseling. Over to Sunil.
Thank you. Am I audible, visible? Can I continue?
Yeah, you are very nicely audible and visible. Sunil.
Thank you. Thank you. I have been practicing teleconsultation for the past 3 years. I was very reluctant and scared to start with, but many reasons forced me to start. So today, the teleconsultation, actually the entire discussion takes more than 4 hours. I'll try to condense within 5 minutes. I'll try to answer the 5 most important questions that you might be asking. The first question is teleconsultation a must or is it optional? And my argument is teleconsultation is a must. I'll tell you 5 reasons why it's a must. The first thing is you are prescribing lab investigations to a patient. They get the investigation. And in the usual course of time, they have to come again to your clinic, wait for you, discuss the lab. It's a painful process. So what I do, I tell all my patients, I give my WhatsApp number. Please send the investigation to that WhatsApp number. Whenever I'm free, after my OP, I go through all the WhatsApp. 9 out of 10, the reports are normal. I just write reports normal, done. So it takes me about 1 minute to scan the lab, 10 seconds to write reports normal. It provides enormous relief to the parents. For the rare patient with a problem, I ring them up, tell this is the problem, what you got to do A, B, C, whatever. So this is the first thing. You can easily solve this problem by WhatsApp. Number 2 is when you're following patients like nephrotic syndrome or hypothyroidism or ITP, all you need is their lab results and see how they are doing. You don't need to really examine from foot to toe. This can easily be achieved by WhatsApp. You can just, they give me the urine albumin or platelet count, whatever it is, and I check them. If I am feeling uneasy, I call them. Number 2. Third is, Lot of patients have counseling question. What the diet my child should take, or what vaccine, or what should I do? I'm going abroad. All this kind of thing? You don't need to meet face to face at all. So this you can do. Certainly, you can consult by video. The fourth is visually identifiable. Suppose I got a rash. Is it chicken pox? It is mosquito bite. Or my child has some scan. Is it serious? All this kind of visually treatable you can do very well using teleconsultation. And finally, life-saving. So my child is not doing well, looking sick. Should I admit? They don't need to come all the way to hospital. You have a look and see if you can easily identify. We are all very experienced to tell which child needs admission. So I just discussed just 5 basic situations which can usually very nicely solve using video, and probably much better than physical consultation. You save so much trouble for the parents, and you save them for unnecessary exposure. I think it's great. The second thing question is, what do you need for teleconsultation? If you are a saint like Dr. Thangavelu, you need only WhatsApp. You don't need anything else. But for mortals like me, I seem to need a lot of money, so you can charge. So all you need is a WhatsApp account. Same, all of us are quite experts in WhatsApp. We do talk to our children, to our grandchildren using WhatsApp. Nothing beyond that. And I have to have a payment gateway. 90% of my patients have a Google Pay, which is very easy. It takes about 5 minutes for you to link your bank account to Google Pay. Even remote village, even the older parties can handle Google Pay. So doctors can easily handle Google Pay, not an issue at all. Hassle-free, you get paid instantly. So you need a WhatsApp account, you need a payment gateway. That's all you're set. But suppose you're seeing more patients. In my peak COVID time, I was seeing more than 30 patients online. So I need to streamline. For those who want to streamline, you can have 2 more things. You can have something called WhatsApp business account. There are a few differences between WhatsApp and business account, but it makes your life easy. So WhatsApp business account. The second thing is you can link your mobile to your laptop. So there is something called WhatsApp web. You link your WhatsApp to your mobile web. You don't have to type anything. For senior guys like me, very difficult to type in the mobile. You can type in your laptop and paste it in the WhatsApp. We have a third option. I can access my desktop, which has IAP software from my home. So I connect to my desktop. If the patients tell me their name and date of birth, I have the entire record I can access. So I know what they already had, what are their allergies, what vaccine, everything I know at my fingertips. So I just use my IAP software. I give them prescription. The advantage is all this is added to my 3C form, which is form 3C. I don't need to separately fill a form. So this is the third thing. The fourth thing is, how about payment? Do you charge? You don't charge. Now it is purely up to you. But what I do is, if a lab consultation, like these are the lab, I don't charge. If they tell me something, sir, I do in the marna kadikala, I have this in the kudukalama, in this all this kind of is all it's clearing. I don't charge. But counseling, what should I do? I charge. All consultations I charge. Some of them they go abroad and they want vaccination certificate. I do charge. So all this you can, because you put some effort there. The final thing is, are there legal issues in this? So Dr. Thangavelu is telling that MCA is going away from teleconsultation. So what he did was, today I downloaded the latest guidelines from National Medical Council, which is dated May 2022. And according to the draft, certainly we can practice, all registered medical practitioners can very well practice telemedicine. There are a few guidelines. You can download it from the net. If you want, I can post the download in our group also. So please do practice. There are some few restrictions, like what list of drugs you can prescribe, list O or A and B, nothing. I went through the entire list of whatever we normally write, pediatricians is all well covered. So safely you can practice the teleconsultation. You can make money. The best thing is, when I keep traveling, I do a lot of teleconsultation. It works well. I don't waste my time. So I think it's a must. It will relieve a lot of anxiety for your parents. I have, in fact, surprisingly, I have many patients from Chennai. They are not my patients. They go to their pediatricians, and pediatricians write the investigation. At night 10 o'clock, they are scared. Sir,
area sorry.
sorry. So I'm sitting at 10 o'clock watching Amazon movies. So somebody, why not? So I went to a lab. So I get paid for it. They are happy. Everybody wins. So I just covered the 5 questions. If you have more doubts, you can contact me anytime. It may be a pleasure to help you out. Thank you once more.
Thank you, Sunil. Your analysis is fantastic. 30 years ago, I referred one child to Sunil.
Yes.
The child went there and when he returned said, the uncle Mohanlal Mar and the uncle Dana. Last year, I referred one patient to Sunil. She came and told me that, oh, the uncle வந்து Shivaji படத்துல climaxல வருவார் ரஜினி அந்த மாதிரி இருக்காரு அவர் தானன்னு கேட்டாங்க. So whatever it is, your analysis doesn't change. Your project in a very way, you are able to convince everybody, including me. Thank you, Sunil. Thank you.
I just want to thank the 89 participants who are still there. I thought 10 பேர் இருப்பான்னு நினைச்சேன் by the time my talk came, but 89 people. Thank you, viewers. Thank you very much.
Thank you. 2 more questions, sir. This
Sir,
is
how
about
many
ethics.
who are the practitioners of Chennai, sir? Whom you have
That is
seen
confidential. Confidential. Confidential.
I'm just telling that.
This is we'll move on to the last 2 questions. Message about ethics from juries. PRC and BB sir to answer. A child comes around 11:30. You are coming out, starting your car or scooter. A child, parent, and child passes by you and goes into the clinic without knowing that you are the doctor. So you got 2 options. Without knowing, silently go home, or you will go back and attend the child and then give the advice. That is first ethics. Second one is a non-affordable patients. Recently, I encountered one of the auto driver brought his grandson with a very proud moment. He brought a child and asked about the vaccines. I was little worried that the cost is very high for his auto driver, maybe 50% or 1/3 of his monthly salary. So are we right in telling them that fortunately our public sector is giving all the vaccines available in the private sector, they can utilize it, and later when some vaccines which are not available there, they can come and have they spend money on that. The third one is lower consultation charges. So I charge a consultation fees of this much. When a poor child comes, can he charge 50% or 1/3? What are the pros and cons following this? Voted at PRC.
Thank you. Regarding ethics, it's a very, very difficult thing to say. If you we have done a few things which now looking back, we think that we could have done better. It is not that are different. All the stages of your life, you are behaving the same way. But still, one would like to feel good at the end of the day. So that point in mind, as Dr. Varadarajan also mentioned, Vivi also mentioned, you do what you would like to be done to your own relative or your own child or grandchild. So with that point in mind, sometimes braving some discomfort to us, some difficulties to us, most of the time, we do tell them like a first situation, would rather go and see that patient and tell them that, or such a patient is likely to be something like a real problem, because otherwise they may not be rushing at that point of time. So we are obliged and we have an obligation to the such type of patient. We have to examine and do the needful. Sometimes it may be difficult. Sometimes you may be having a CME program or a lecture to do. All this are there, but you can always, your colleagues will understand. So you can always do that. The second situation is most of the time the patients who cannot afford certain things like vaccines in practice, we do advise them. We tell them that whatever is available to be taken, and as per the government rules and regulations, what is not available, they can come back to us. So some patients say that in spite of that, they will, they would like to take with us, then we'll try to minimize the cost and acceptable vaccines which are of lesser cost, we use them. So this is also an option. I mean, 2 things only you asked, no?
Yeah, third one, sir. What differential charges?
Differential, we do charge differently. And of course, all of you have been doing that also. Some patients we don't charge also. I don't think any of our patients is that and saying that you charge less for that patient and you are charging more, because more pediatricians generally are charged less only. They don't charge that high. So there is not much that patients have to complain about. That is my personal feeling.
Thank you, sir. BB, sir. Dr. BB. he is not available, move on to the next question. This is a lady, great lady, Muthulishma Reddy. She's the first female student in the men's college, MMC. Graduated from MMC in 1912 as the first women doctor in India. One of few of the first women doctor in India. First women legislator. Became the first woman housed in government maternity hospital. She fought for equality for women. And she, along with Shanta Madam, founded the Cancer Institute of Vadayar. Great lady. I have a lot of respect for her. Last, all of them, all the faculty, we have come to the end. We have come to the end. The single line, one line message from all the practitioners. I think we can go in alphabetical order. One line message, not exceeding 30 seconds. Amal Raj, you can start with Amal Raj.
Yes, sir.
Follow the alphabetical order.
Yes, sir. My advice to my junior colleagues would be always maintain harmony with your neighbors, sir. Especially in a clinic setup in your immediate neighborhood, next to you, opposite house or opposite people, create an harmony because it helps in the long run. We can even give some concession also. It is beneficial, sir. One way, number clinic they'll be our propaganda members actually. The doctor Papa in the time that helps a lot, and it always keep good harmony with your neighbors, sir. Clinic Porto Rico, sir.
Thank you, Amalraj. I agree with you. In the coffee late upon cleaning late coffee filter coffee. Nice. Thank you, Amalraj.
Sir, advantage car parking issues, sir. Parking sir.
Okay. Nice. Arulalan. Arulalan. Next, list in land. Sir, Brindagiri, sir.
Sir, one should be, the pediatrician should be first receptive to the mother. Lending ears to the mother. Next thing is communicate to the child, communicate to the parent, tailored to the level of the mother and the language which she can understand. It should be clear, but it should be very it should bring behavior change with the mother.
Thank you, sir. Selvan.
Be truthful to the patient about the disease and the treatment.
Very crisp message. Selvan.
That's all, sir. One line.
Fantastic. Crisp message. Lalit.
So be friendly with the patient. When child is doing something wrong, mother says, I whisper something in the child ear. Say that if you do properly, next time I'll give you a gift. They be happy and say mother not to ask what secret I have spoken with the child. So they feel very happy and delighted. And I don't charge for physically challenged and mentally challenged children, sir.
Great, compassionate pediatrician. Great. Mahalinga, sir.
For a successful pediatrician, sir. Am I correct?
Yes, sir.
First, most and the important thing is your availability, sir. So long as you are available and you try to expand your time for the sake of patients, then you will be a successful practitioner. And the next one is the politeness and patient enough to explain everything. Even though I am fast enough, but I never shout out the patient, and I will be politely explain everything. And the most important thing, even today, of my more than 40 years of practice, even in Sundays also, I am working, sir. I am working, that is mean, I am working, coming down to the OP as well as for the IP also. So that availability is more important thing that makes the patient very comfortable. So whatever the time we go, almost we can see the doctor. That is the key note for the success of the practice.
Thank you, sir. TN Manohar, sir.
1 second. Maintain time, be empathetic, be compassionate, and communicate well to be successful.
Thank you, sir. For a crisp message. Palli.
Even after 2,500 years, that is the father of ancient medicine, Hippocrates' statement still always true for in the case of medicine. To comfort always, majority are benign viral illness. Your tongue plays a major role. To treat often, just a paracetamol or supportive cough syrups are more than enough. and to cure rarely. Antibiotics are needed rarely. So to comfort always, to treat often, and to cure rarely, the father of ancient medicine told over 2000 years back still holds true even for now. Thank you.
Hippocrates' message is blessing to you, Palniraman. Raju sir available. Raju, if he's available, you can.
No.
Or I will ask Satish.
Not available. Not.
Satish.
Sir, I just want to say only to quote two people. One is MGR, second is V. Balagopal Raju. What MGR says that in Vahalvakyum Devangale, similarly, their patients are their Vahalvakyum Devangale, and therefore, Chalipe irkam practice panano, whatever be the years of experience, whatever be the seniority. And what BBRs are told, I may be pardoned if I'm unparliamentary, particularly in front of my teachers, my senior colleagues, and my friends. But I'm quoting him. He has his own way of spreading messages in a nice way, in a humorous way. He said, a practitioner, a doctor is like a prostitute who has to be there with the same entertaining thing, whether it is beginning of the day or end of the day, the same smile he has to receive this client.
Thank you, Satish. Sunil?
Yeah, my message is be a Buddha. I'm sorry to be spiritual here. When I left, finished after DCH from JIPMA, I was totally didn't know how to practice. So I always keep in mind, how will Professor Srinivasan react? In this patient, he was my mental guru. Or if whatever he does, I thought I should do. And now I got more heroes, Dr. Namalwar, Dr. Thangavelu, Dr. PRC. So now I know. So that is my guidance. So be a Buddha and you will become one. Thank you.
Sometimes நீங்க கூட போய் சொல்றீங்க. என் பேர் தான் சொல்றேன், மத்ததெல்லாம் சொல்ல. திரு சொல்லுங்க, திரு.
Sir,
நீங்க தான் brigade. சொல்லுங்க.
3 things to say, sir. Be honest, be sincere, and be trustworthy. That's all I think about. Patient has to be, நம்ம அவங்களுக்கு உண்மையா இருக்கணும், நம்பிக்கை வந்தவங்களுக்காக இருக்கணும். நாம நம்ம வேலையை ஒழுங்கா செஞ்சோம்னா will be very successful. And சுனில் சார் சொன்ன இது எனக்கு இன்னும் சார், இன்னைக்கும் என்னோட ஒவ்வொரு பிரெஸ்கிரிப்ஷன் நான் எழுதும் போதும் இந்த பிரெஸ்கிரிப்ஷன் சீனிவாசன் சார் கையில மாட்டினா என்ன எப்படி திட்டுவாரு அப்படிதான் நினைப்பேன். அதுக்காகவே பயந்து எழுதுவோம் சார்.
உங்களையும் கனவுல பயமுறுத்துறாரா என்ன மாதிரி?
தேங்க்யூ சார்.
தேங்க்யூ திரு. Annamalai Vijayaraman sir did lot of help for this session. So Annamalai Vijayaraman sir, நீங்க ஒரு 1 minute எடுத்துக்கோங்க. எல்லாருக்கும் 30 seconds, உங்களுக்கு 1 minute தரேன். டைம் எடுத்துக்கோங்க. இல்ல மெசேஜ். Vijayaraman இருக்கீங்களா?
Yes sir. Very useful messages from all the faculty, right from starting the clinic, how to look for danger signs, how to go about the problems, and expert advice by our jury. And we have some suggestions by the viewers. One of the viewers, Dr. Vishwanath, has suggested that always we should mention that there is no drug allergy in the documented, so that it will be
a nice point. We should mention the drug allergy. Very good point, sir. Thanks, sir.
We have asked for it. And another thing is that he also mentioned the combination drugs like paracetamol with other drugs could not be used. So these are some of the important from the audience. We have got some important points. And thank you all the panelists for telling all the views how you have succeeded right from the beginning, what are the difficulties you have encountered, how you have got about it, and then now what the best is you have advised the youngsters who are going to start the practice now, what all they should do and what they should not do. So by this, the youngsters would have definitely, and Dr. Thangvel sir has prepared nice slides about the great teachers we had in the past, about their contributions, most of them. And also I had given a suggestion to Dr. Thangvel sir that we should have some lady practitioners for the second session, because this time lot of photos shown were from Madam Pushpa and others. So next time I think he will include some of the panelists, lady doctors who are good practitioners who are also very busy. And with this, I thank Dr. Thangavelu for allowing me to moderate, or at least the time, because he was particular that everyone should not overshoot their time. So we have exceeded, thanks to the IAP, we have exceeded only by 25 minutes.
Thank you, sir. Thank you, AV, sir. Thank you very much. I think it's a very nice write-up by nice advice from Hutchison clinical methods. I think this advice is almost, it looks like a new one for us. Let me, he tells the doctors and practitioners, let me advise you not to aim too high. The big prizes in our profession are only for the few, and they do not always bring much happiness when gained. Seeks you great things, seek them not, as the wise man said. We have earned enough for your needs and been able to put a little aside for your old age. And if at the same time you have won the esteem of your colleagues and the affection of your patients, you have done well enough, and that measure of success should be within the reach of most of you. It was told in, probably he lived between 1871 to 1960. After 60, 70 years, still it holds good. It's fantastic message from Hutchison's clinical methods, Arthur Hutchison. So that's how he defines success. I'm so really thrilled to see this message from him. Thank everyone. All the definitely special thanks to Dr. Annamala Vijayaraghavan, Vice President of IAP TNSC, my dear friend Ramesh Babu, President, Secretary Dr. Rajendran, Dr. Gopal Subramaniam, and then Thiru for patiently doing all the software work, and all the IAP functionaries. Thank to you, and the faculty who was literally, I troubled them for the last 3-4 days, troubled them with a lot of questions and changing the questions. Thank you so much for your patient cooperation, and also thanks a viewer for your participation and listening to us. If we didn't have time to listen to your comments and then answering that, probably if IAP permits, we'll have a part 2 in which we can have new messages. Thank you very much. Thanks a lot.
Sir.
Thank you very much, sir. Thank you for the opportunity.
On behalf of IAP TNSC, I thank Dr. Thangavelu, sir.
Rajendran, just a minute.
Yeah.
Rajendran?
Yes, sir, Ramesh.
We learned a lot from the legends and stalwarts, sir, today. Apart from subject, we learned a lot which couldn't be found in books. Only one more thing I want to add, sir. For the upcoming generation, for the future pediatricians, or as well as the existing pediatricians, I request all of them to join the IAP family. At least have a monthly get together where you can share your, not only your knowledge, you can share like these sort of things and practical difficulties you face in the present scenario of practice. And I request all of them to go to the community. They do not go to the community means go and treat the organize camps like that. To plan some activity as a charity activity for the downtrodden, underprivileged children, orphan children. We can, in our visit and all, I have seen many children left out by their parents as an orphans and all. So these sort of things we should be able to do only in the banner of IAP, so that we can, all the pediatricians, if we have a monthly meeting and all this scenario, post-COVID scenario, COVID pandemic and as well, we can meet physically also. Plan some activity at least once in 6 months or like that, so that the community pediatrics also, we can find out the other causes which will helpful to improve the status of the underprivileged children, sir. Thank you, sir.
Thank you, and
one more thing, sir. We can reach out to the schools and colleges on preventive medicine and earlier counseling also.
Yes.
Thank you,
other
sir.
than the community.
Yeah. On behalf of IAP TNSC, I thank Dr. Thangavelu, sir. Pata or Bahubali at the Padang. பாகுபலி 1 எடுத்தாச்சு and 2 நம்ம வந்து ஆகஸ்ட் 2nd எடுத்துலாம்னு இருக்குங்க சார். பண்ணிடலாமா சார்? டைரக்ட் சார் ஓகேனா ஓகே பண்ணிடலாம். So I think we left our topic. Shall we cover on second Sunday, sir? That means August, sir.
Yeah, definitely we can do it, sir.
சார் ஓகே நானா பண்ணிடலாம் சார்.
நீங்க தான் ப்ரொடியூசர் ஃபைனான்சியர்
சார் வந்து ரொம்ப டயர்சமா இல்லனா பண்ணுங்க சார்.
பண்ணலாம் நல்ல நிறைய இருக்கு.
இது வந்து இதுல எங்கேயும் நம்ம டெக்ஸ்ட் புக்ல ரீட் பண்ற மேட்டரே இல்ல. இது எல்லாமே our own experience and like legendary like கபில் தேவ் and கவாஸ்கர்ல இருந்து டெண்டுல்கர்ல இருந்து இன்னைக்கு பாண்டியா வரைக்கும் எல்லாமே இன்னைக்கு ப்ளே
இல்லதான் என்ன நிறைய நானும் லேர்ன் பண்ணிட்டேன். எம்எஸ் விஸ்வநாதன் வந்து டபுள்ல காம்பினேஷன் கூட சொன்னாரு. விஸ்வநாத் ராமூர்த்தி வேண்டாம், விஸ்வநாத் போதும்னு சொல்லிட்டாரு இல்ல, சிங்கிள் ஆன்டிபயோட்டிக். அந்த மாதிரி நிறைய லேர்ன் பண்ணிட்டேன். எல்லாருமே நிறைய லேர்ன் பண்ணிட்டேன்.
This is I think it's not in textbook, no. It's definitely you learn a lot. And on behalf of IAP TNC, I thank Dr. Thangavelu sir for his wonderful effort. And I say whenever he is involved, it's 100%. I can tell 200% commitment. That's
my 70% of the congratulations message to Mahendra.
Yeah, thank you, sir.
The person to be well done, Mahendra and Dr. Thangavelu.
Thank you very much, sir. Thanks for all that.
Thank Dr. Mahendran, and Mahendra is also helped a lot for that. Dr. Thangavelu sir. I thank legendary pediatrician Dr. P.R. Namalwar sir, Dr. P. Ramchandran sir, and Dr. V.V. Varadarajan sir, and resource persons Dr. Amalraj, Dr. K.V. Arularan, Dr. Lalit Kumar, and Dr. Mahalingam and Dr. Manogar sir, T.N. Manogar, Dr. R. Palniraman sir, Dr. Raju, and Nadish, and Dr. R. Selvan, and Dr. Sunil Srinivasan, Dr. Thirumurugan Sarani, and Dr. Virudagiri sir. Actually, they done almost the pan Tamil Nadu. No? They organized and got resource persons, and really definitely it be benefited for our pediatricians. As sir said, no, that's current pediatrician as well as upcoming pediatrician also definitely useful. And we will again allow that's a practicing pediatrician. We have a meet on the second Sunday. I think August 2nd Sunday. I think I will continue whatever the leftover topics. Thank you very much, sir. Thank you.
Thank you. Thank you, everyone.
Thank you, sir. Thank you, sir.
Thank you.